माईक घे ना, मी तुला कॉन्टॅक्ट करतो. नाही तर तू हॉलमध्ये ये, तुम्ही कॉन्टॅक्ट करू, चालू करू, कोणी येऊ न येऊ आपल्याला चालू करायचं, कारण ऑनलाईन लोक आहेत ना. हां हां हो हो. ऑनलाईन
हॅलो.
हॅलो.
हां भास्कर.
हां डॉक्टर सुशील.
हां. हॅलो.
हॅलो.
हां.
Can you hear me?
Yes, yes, yes.
We are ready with the first case. So very soon Dr. Praveen sir will be demonstrating the first case.
Okay, okay.
Oh.
Yeah.
Hello, hello.
चालू है क्या? Good morning to one and all. Welcome to day 2 of 3rd ENDOSURG 2025 Endoscopy for Surgeons. We'll be starting with first case with Dr. Praveen Suryavanshi sir. A 41-year-old female came with complaints of pain in abdomen in epigastric region, post-meal since 2 months, and postprandial fullness. In investigations, there was only amylase and lipase raised. Amylase was 112 and lipase was 223. Rest all investigations were normal. On CCT abdomen pelvis, there was a large cystic lesion, 450 cc, with wall thickness of 4.6 mm, replacing most of the pancreas. There was MPD communication present. The pancreatic duct could not be seen separately from the collection. The plan is endoscopic cystogastroscopy, SOS, PD stenting.
Over to Suryavanshi sir.
Hello.
Hello. Good morning, Dr. Praveen.
Yeah, good morning.
Sushil here.
Yeah, Sushil. So, can you see this image?
Yeah, I can see you, but not the image. Yeah. Now I can see the image.
Yeah.
US. Yeah.
See now, this is a pseudocyst,
Yes.
okay, in the
Yeah.
lesser sac. And what is the best part of EO is that you can exactly assess the amount of necrosome inside the pseudocyst.
Yes.
So you can see at the posteriorly at the bed of the pancreas,
Yeah.
there is a necrosome. Okay.
Yes.
Huh?
Yes. Yes.
So if you see, this whole necrosome is occupying less than 30% of the volume of the cyst.
Yes.
So this is the indication for the endoscopic necrosectomy or cystogastroscopy.
Okay.
If this necrosome is more than 30% of the cyst cavity, then we should not do endoscopic cystogastroscopy. Then the surgical necrosectomy is a better option. Also, you can see the content of the cyst, which is quite homogeneous, hypoechoic and homogeneous.
Yes.
So there is no any sepsis or bleeding inside. So this also has to be looked, before you do endoscopic cystogastroscopy. So
Yes.
basically, the cyst should be uncomplicated, and
Okay.
the necrosome should be less than 30% of the total cyst volume.
Okay.
So these are the, and again it should be in proximity of the lumen, whether gastric lumen or the duodenum.
Yes.
Okay, then only endoscopically it's possible.
Okay.
Okay, and again it should be solitary. If there are multiple, then again either if there are pockets in the paracolligator, you may have to go for another technique for that,
Yes.
like retroperitoneoscopic or percutaneous.
Yes.
But it's solely if you want to treat any patient by any monotherapy, then there has to be a solitary pocket in the lesser sac in close proximity of the stomach.
Okay. So how do you plan to tackle the less than 30% of necrosome?
So again, that's what now there are multiple ways. First, we can just puncture like what we used to do conventionally with the puncture, aspirate, dilate the tract with cystotome, and then
Okay.
put the multiple plastic stents. Okay,
Okay.
but problem that these stents used to get blocked, and sometime they themselves used to introduce infection.
Yes.
So I have seen many patients where there was initially non-infected pseudocyst, and after procedure it became infected and patient came in sepsis,
Yes.
and when this stent got blocked. So all these issues are there. So I was not really in favor of doing that. Being a surgeon, I used to
Yes.
do a wide cystogastrostomy surgically, laparoscopically, that too.
Yes.
So in this Panther trial, what was mentioned, that with step-up approach, when patient is unstable, so to just tackle the that critical situation, do percutaneous drainage,
Okay.
and once patients are stabilized, or minimum 4 weeks are passed, whenever
Okay.
there is a wall of necrosis is there,
Yes.
then that should be treated with minimal invasive approach.
Okay.
Okay, so that minimal invasive approach can be endoscopic, it can be retroperitoneoscopic, or it can be laparoscopic also. So it doesn't mean that minimal invasive means endoscopy only.
Okay.
Only thing initially what it was discussed that endoscopically the fistula formations are less. This pancreatocutaneous fistula, because you are not draining anything outside.
Yes. Yes.
Okay, the same way laparoscopically we can do transgastric and do transgastric extensive necrosectomy,
Yes.
and in that case also there is no chance of any fistula formation.
Okay.
So we are giving all benefits of minimal invasive
Yes.
plus extra advantage of extensive necrosectomy, even in complicated cases if there is a bleeding or sepsis,
Yes.
that also can be managed in a very efficiently laparoscopically. And not only that, if there are another extra pocket away from the stomach, like paracolligator, pelvis, those pockets also can be dealt with in the same setting.
Okay. So for all the pseudocysts, US is must?
Yeah, of course. See, for the assessment of the amount of necrosome and all that, and also complication, US is better. And not only that, for the selection of the site and avascular area, and
Yes.
for everything, US is a good choice.
Yes. Is there any maximum number of attempts of necrosectomy? If you do cystogastrostomy, put in a stent, are there any number up to which you can try removing necrosum endoscopically or and otherwise convert it into laparoscopy or surgical intervention?
See, they have not mentioned any number. Even unfortunately, in most of the paper I have seen, whenever they do endoscopic necrosectomy, attempts they have not mentioned in how many attempts they cleared all necrosum.
Okay.
Okay.
Yes.
But most of the time, these patients are referred only when they land up in some surgical complication.
Yes, yes, definitely. That is the main issue.
So what today we are using is a advanced, this stent deployment system by the Boston Scientific, that is
Okay.
hot axis.
Okay.
So this is a cell lumen opposing self-expandable metallic stent.
Okay.
Okay. So it's a better option than just putting the plastic stent. So
Okay.
if I have to do anything endoscopically for
Okay.
pancreatic pseudocysts, I will use this self-expandable stent, not any if it is a complete clear-cut pseudocyst, we prefer to do trans-papillary drainage.
Okay.
And then the cystogastrostomy.
Okay.
So only where there is a necrosum like this,
Mhm.
which is uncomplicated, we
Okay.
do this endoscopic.
So after the deployment of this stent, how big is the opening? Like, what is the diameter?
So
which
today
you-
we are using stent. After opening, it will be 20 mm
Okay.
with 10 mm depth for the stent.
Okay.
Okay. So the flank of this stent,
Okay.
which will hold through the stomach wall and the cyst wall,
Okay. Okay. So
that is 10 mm.
okay. So there is no chance of migration of the stent.
No. So first step. First, now we are introducing the system inside. Okay.
Okay. Okay.
Can you
Yes.
appreciate?
Yeah. Yeah. We can see.
Ah.
Yes. Please. There is
See,
no.
I have
US
entered
picture.
inside. Are you see?
No, actually,
Can
there
you-
is no US picture now. Yeah.
Arre?
Now we can see. Yes.
Yeah, sorry.
You are inside the.
I am inside the
pseudocyst now.
pseudocyst.
Yes. Yes.
Okay.
Yeah.
Now I will. Okay.
Yes.
Now I am deploying this distal
Okay.
flange.
Yes, we can appreciate that.
Screen. So can you appreciate on
Yes,
CM?
yes, yes,
It's
yes,
getting
yes,
open up.
yes, it's-
See,
Yes, yes.
open. Huh?
Yes, yes. Very
Both
well
on
seen.
EUS
Yes.
and CM.
Yeah, on both pictures we can see.
Yeah.
Yes.
Now, yeah. Up. Huh? So now I am pulling the whole
System back, yes.
system back.
Okay.
So this distal flange gets stuck against the
Okay.
cyst and the gastric lumen.
Okay.
ठीक है?
Yes,
This how.
yes. Yes.
Okay. Now I am deploying proximal part of the stent,
Okay.
which get deployed inside the scope itself.
Okay.
ठीक है? Now, screen. ठीक है.
Yes.
Now what I will do, I will just rotate the scope.
Mhm.
एक मिनट. See, can you
Yes, I
see?
Yes, I can.
Deployed completely.
Yes, yes. Yes. So endoscopic picture is also there now. Yeah. Do you need to take any special precautions, like there is huge cyst and then the gush of fluid will come?
Yeah. So prefer this patient should be intubated
Yeah.
if it is a large volume cyst,
Yes.
and or you try to suck it out.
Okay.
See, now all this fluid has एक मिनट हाँ. किधर गया रे? हाँ, suction sir. See, all this fluid are already,
Yes.
there in the gastric
Yeah.
lumen.
Yes, it is empty now. No.
This is all
Fluid.
fluid
Yes.
which has been drained into.
Yeah.
We can see on table the cyst is getting decompressed.
Yes, yes, yes. So these stents can be, this type of modality can be given, offered to the patient only where the US facilities are available. Or
Exactly.
Okay.
It is mandatory.
mandatory.
Without US, you cannot do it.
Okay.
Because
So
this
somebody else does US and you have ERCP facility and you can do it at your own place. It's not possible. You have to have the
everything, yeah.
everything at one place.
See, what has happened, this technology has made things simple and easy.
Yes.
But problem is that where to use this technology, that decision we have to make.
Yeah. Yeah.
So that has become very critical now.
Yes. That is challenging. Many
Challenging.
times. Yes. Does this stent remain inside body lifelong or?
No. After once everything gets collapsed,
Okay.
we can pull it out.
Okay. So for removing the necrosum.
Yes, I'm
we
sucking
can-
it out.
Okay. And then we can go inside the, put the scope inside the.
No.
stent.
This is just, as I mentioned, this is 20 mm.
Yes.
So while putting
wide
in
enough.
at this stage,
Okay.
you may dislodge it.
Yeah. Okay.
So
So-
maybe after 2 weeks if required,
Okay.
when there is a well granulated tract is formed,
Oh, okay.
then you can
Yes, we can try.
try,
Okay.
and that too with gastroscope, not with the
Not wider scope.
this EUS.
Okay.
Sort of change position there. See, this is a stent. Can you
Yes.
appreciate now?
Yes, yes.
It is submerged in the secretion, you know.
Yes.
ठीक है?
Yes.
ठीक है ना रे? Can you appreciate now?
Yes, yes. We can
Huh?
very well see. Yes. Lot of
Screen.
fluid coming out.
Screen. See,
Yes, yes.
this
And
is the gastric fly, and that
yes,
is
and
inside
the
this.
distal one. And the US is showing collapsed
Yeah.
cyst also. Yes.
Screen EOS motor kar. So this is now the
Yes.
huh?
Yes, yes. Completely
Collapse.
drained
Yeah.
pseudocyst.
Only this necrosome is there now.
Yes, yes.
See, this necrosome is there.
Yeah.
All fluid is drained
All
completely.
fluid is drained. Yes.
Okay.
Yes. How much is the cost of this stent, by the way?
That's another problem. It is costly, and they don't give any concession to the poor also,
Okay.
because all these medical gastroenterologists, they
Mhm.
can afford. We surgeon cannot afford it.
Mhm, yes. Not for everybody then.
Yeah. Only. It costs 1,75,000.
Okay, but if we consider
This
the
cost-
advantages,
Just cost of stent.
yes, of course.
Mm.
Surgeon, they don't charge anything. They are not expected to like.
Ah.
Very well.
Thank you so
demonstrated,
much.
yes. Really nice
Yeah.
demonstration.
Thank you. Thank you.
Shifting to OT3, procedure by Mandar sir.
Bo.
Good morning, Dr. Mandar.
Good morning,
we are
sir.
with you now. I'm
Yes,
Sushil Deshpande.
Hi, sir. Good morning, sir.
Good morning.
So this is a case of Hilar CA.
Okay.
I think the houseman will give you the history.
Yes.
So the
yes,
plan
yes.
is to go for stenting. Now,
Okay.
to save time, I have already gone inside.
Okay.
And this is the ampulla of Vetter. And I'm trying to cannulate.
Okay.
So yesterday I was lucky. In both the cases, the ampulla was very conducive. I could cannulate very easily. But today, it looks little more difficult. So I'm
So-
trying.
More challenging case for the next day.
Yes. Bo. Full.
Can you have the details of the patient, please?
Wire. Having the wire.
73 years old male came
Nae.
with complaints of yellowish discoloration of eyes and urine since 15 days.
Unbent. Unbo.
Pain in abdomen since
Pre-cut hai?
15 days and itching over the body since
Yeah.
15 days. Lab investigation
Really?
suggested of serum bilirubin total was raised of 17.9 and bilirubin direct was 16. Alkaline phosphatase was 525 and CA 19.9 was 8,220. UAG abdominal was suggested of gross IHBR dilatation, possibly isolated with hypoechoic lesion noted involving CSG and visualized CVD. Suggests possibility of neoplastic mass lesion, possibly cholangiocarcinoma. CECT abdopelvis approximately 3.5 by 3 by 2.9 centimeter, mildly soft, enhancing soft tissue
Now hold the
density,
scope.
mass lesion in portal region involving proximal CBD, CSD and right and left hepatic ducts. Features suggestive of cholangiocarcinoma. Tumor is seen encasing right hepatic artery. The MRCP was suggestive of well-defined solid lesion involving confluence of right and left hepatic ducts, causing significant biliary obstruction with impacted calculi within the lesion. Features suggest of Hilar carcinoma, post-cholecystectomy status, prominent portal vein, and mild splenomegaly. Plan is for ERCP with metallic stenting. Over to you, Dr. Mandar sir.
Yeah. So I tried simple wire guide cannulation few times, but it is not happening. So I have decided to go for pre-cut. Okay. So I have inserted the needle knife.
Okay. So before, like, as you are cannulating and all, can I get your idea about how you decide about whether to go in for stenting or surgical management? Here there is encasement of the vessel, so clear cut.
Yeah, it's an inoperable case. So the plan is to just do palliative stent placement.
Okay, so
it's a Hilar cholangiocarcinoma.
Yes.
With advanced tumor.
Yes.
The needle. Yeah.
So main issue is arterial encasement rather than involvement of the portal vein. For sign of
कमी करा था needle, कमी करा length of needle, reduce the length of needle. Yeah, fine. So now, if you can see, it is a bulky ampulla with a long common channel. Hold the scope. Hold it properly, sister. Slipping out. Yeah. Needle. कमी reduce, yes, थोड़े वाड़वा, yeah. So as you can see, only a small part of the needle is out.
Yes. So for a pre-cut, what is the approximate length up to which you cut, or till the time you see the lumen?
Yes sir, so basically we call it more of excisotomy. The overlying mucosa I am going to cut. So this is the common channel. So it's called, basically it's a de-roofing.
Okay.
Needle. Reduce the length. Sister, reduce the length of the needle. Hold the scope nicely. Don't let it slip out. Needle. द्या परत. कमी. Reduce the length. Yeah. Out, back, hold the scope. So did you see, sir?
Yes.
Now probably I have cut the overlying mucosa.
Yes.
And now probably I should be able to cannulate the CBD. Yes, now I'll not continue with the needle knife. I'll change for the sphincterotomy.
Okay.
Good morning, Dr. Mandar.
Good morning. Hi.
I would like to ask you, when do you feel a pre-cut is needed?
So, see, the thing is, it depends on the threshold. So I tried, see, when I saw the ampulla, that time only I thought wire-guided cannulation may not be possible. That time see, this was a bulky, long papilla with a long common channel. In such cases, sometimes, plus these patients, he has obstructive jaundice. So because of bile not coming down, the entire system becomes more dry. So the cannulation becomes that much more difficult. So if you attempt for, either it will depend on the number of attempts or time. And of course, your own experience. wire ana.
Any number of attempts, like 2 or 3 or anything?
Around 3 attempts. In my case, bus. Around 3 attempts I will go for. If I am not able to cannulate, then release me. Wire चा tip द्या मला. Sister, wire, tip of the wire. Tip of the wire. I want the tip of the wire. Don't do anything, sister. Bow. हाँ, थोड़ा सा, खूब नहीं. कमी करा बो. वायर द्या. वायर. इकडे बघा रे तुम्ही केस चालू असताना. बसकोबन दिलाय मॅडम. बघा वायर सिस्टर. Okay. Probably I have gone in.
Yes, looks like.
Can I see the Siam? So we are in the CBD.
Can
now
you get the Siam picture, please?
मागे गया सिस्टर. मागे गया वायर. मागे गया. मागे 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 पूर्ण मागे आत येऊ दे. Can you just move? I want to see that. Now go. Try again.
We are not getting the Siam picture.
आता स्कोप पकड़ रहे. Yeah.
Yes, now we can see.
Hard?
Yeah.
Yeah, good job. So, sister was very good. She was able to go beyond the stricture.
Yes.
So, mind you, in such cases, the role of your assistant is very important. You can only take him or take her to the bile duct, but
Rest
to
all,
go
yes.
beyond the stricture is all her skill, and she has done a great job. So now, since this is a case of hilar cholangiocarcinoma, I will not be putting any contrast. Instead, I will be doing what is called as air cholangiogram.
Okay.
So for that, I will ask her to aspirate some bile first.
Okay.
Pakado me. Because you just instill air, the pressure inside the bile duct can go up, and that can cause some bacterial transformation.
Okay.
Aspirate, 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 aspirate. And the patient will also experience some pain.
Yes.
Hello? White bile sir. Yeah. Bagu. So this is classic white bile. Can you see, sir? Are you getting the external?
Yes, yes.
हे कल्चरसाठी पाठवून द्या. अजून एक त्यांची सिरिंज घ्या. Now sometimes the strictures are very tight and you are not able to go beyond the stricture in the first go. In that case, what we do, we will extend the papillotomy first,
Okay.
so that your entry into the bile duct becomes secure. Now थोडं हे कमी करायचं. केवी थोड़ा कमी करा, डार्क करा, डार्क, हां थोड़ा डार्क करा, बस बस शूट करा, बघू मला एकदा, हां इंजेक्ट, हो इंजेक्ट करा जोरात, एकदम जोरात, येस बस ओके ठीक है. सर कैन यू सी द एयर कोलेंजोग्राम, द लेफ्ट सिस्टम इज वाइडली डायलेटेड. अजून थोडं कमी कर रहे, केवी अजून कमी कर, थोडं डार्क करायचं आहे मला. शूट आता दिसतोय सर. कॅन यू अप्रिशिएट द एअर
On the left side.
हां ऑन द लेफ्ट साइड.
Yes, yes, yes.
It is I think bismuth type 2 B, or you can call it type 2B or even type 3. So now I'll just extend this guide wire. Badla.
Okay.
So since we are doing it only for palliation,
Yes.
I'll be putting a stent on the left system.
Okay.
MRCP also showed the system on the left side was more dilated. So my plan was to put a stent on the left side system only. Ideally, we should try and cannulate both the ducts separately and put stents in both the system.
Yes, so as to decompress both.
Yeah,
the systems.
yeah.
Yes.
Dr. Mandar, if it was a resectable case, would you put in a metallic stent or
No,
a plastic?
definitely not. Plastic stent.
Yes.
Shoot. Yeah, good. Bas, bas. Now when I'm coming out, I have to measure the distance of the stricture from the tip of the ampulla, so as to decide the length of the stent which we are going to use. The stent come in different sizes, 6 centimeter, 8 centimeter, sometimes even 10 centimeter stents are available.
Okay.
So depending on the distance of the stricture from the ampulla, you have to see like this. I have calculated from where the stricture was started, and this much stent length should be needed, so that the distal end of the stent comes out of the ampulla. Now I'll be extending the papillometer. Bend kara thoda, bend, bow, and cotrillava. So I'll extend the papillotomy.
Okay.
Because that will help me in putting the metal stent.
About the extent of stricture, you said like. Now
Sorry?
how do you judge? Is it over the as
Bend,
you feel?
bow. Sir, एक मिनट, I'll just confirm.
Okay.
मगाशी तर चालले होते. So I had kept the tip of the ampulla, tip of the cannula within the left hepatic system, beyond the stricture.
Okay.
And as I was bringing it out, I had kept my finger at that point. And when the tip came till the ampulla, so I measured that much distance outside.
Okay.
काय झालं? नाही तर काय वापरतोय मी? बस I'll exchange. Press करायचं सर ना, I'll me बाहेर काढ. So I think this much papillotomy is enough.
Okay.
It should be wide enough to accommodate the metal stent.
Yes.
So you don't need a very big papillotomy in this.
Okay.
Shoot. While we are doing this exchange of the wire, you should keep an eye. Bas. Sometimes the wire can slip out.
Okay.
Bas. So endoscopically you can see the wire whether it is moving or not, but it is always a good idea to keep a watch on the fluoroscopy also.
Yes.
8 centimeter है, 8 है, एक मिनट, हाँ बघू, 10 आहे हा किती आहे? तोच आहे का? but ठीक है क्या चल. So we are using 10 centimeter stent.
Okay.
Uncovered है ना? Uncovered है ना? And since we will be going in the left system.
Okay.
Bagu? So we are using uncovered stent. Why uncovered? Because we will be blocking the cystic duct opening. And if we use covered stent, sometimes that covered stent will block the cystic duct, and that can lead to post-operative cholangitis, cholecystitis. But I think in this case it is not relevant because the patient has already undergone cholecystectomy. Yeah.
Yes. There is also chance of blockage of pancreatic duct with a covered stent, which leads to pancreatitis later on.
Not so much because we have done papillotomy. No,
Okay.
so that separates the PD opening from the CPT side. Oh, pull. Slowly. Shoot. Yeah. Pull, sister, pull. Keep a traction. Pull. Now this stent has two markers. One is the endoscopy marker and another is the radiology marker.
Okay.
I'll show you. Okay, now my stent has come out.
Yes.
Now passing this stent is also little tough. Shoot. Shoot. So this is the distal marker.
Okay.
Sorry, proximal marker. Now that proximal marker should go beyond the level of the stricture. And now I will look for the distal marker. So this yellow thing, can you appreciate on the endoscopy,
Yes.
sir?
Yes.
So that is the distal marker endoscopically. Similar marker you will find on the fluoroscopy also. So
Yeah,
I
we
have
can
to
see
make
that,
sure
yes.
that this marker remains outside.
Outside.
Now I'll ask her to start deploying. So while she is deploying, sometimes the stent can get pulled in. So particularly if you are doing it a case like ampullary stricture or periampullary carcinoma,
Okay.
and sometimes while deploying the stent, sometimes that entire stent can go migrate inside.
Okay.
So in this case, that problem is not so relevant, but otherwise you have to be careful.
So what do you need to do for?
So you have to keep a traction outside.
Okay.
Madam, can you just move? I have to. Thamba. Yeah, start. So as she is releasing the stent, होता है? Yeah. Start. Kara. Yeah. See, it is going. But thamba, sister, halu. See, you saw that it went inside.
Yeah.
So you have to be very careful, and you have to keep a touch. Slow kara, sister. Ekdam slow.
Yeah, on fluoro we can see it opening.
Yeah.
Yes.
Kara. Wait. So I am keeping a traction. I am literally pulling the stent out.
Okay.
So that the position remains stationary. When the second marker comes near this third marker, so from that is a point of no return. Till that point you can retrieve the stent. Wait. Now even if I want, I will not be able to close the stent again.
Okay.
Really? Okay, now the stent is deployed.
Yes.
You can see the bile gushing out.
Yeah.
And sometimes this gets blocked within the stent. So there also you have to be careful. Shoot. Yeah. Now it has come out. Now you can see the bile draining nicely.
Yes, we can.
You see the proximal portion of the stent that is in the dilated part of the CBD.
Yes.
Those markers are there. Those markers will remain. Those are the radiological markers on the stent.
Yes.
And this is the distal part of the stent. This yellow thing, can you see on endoscopy?
Yes.
That is also radiological, it's a radio opaque thing.
Okay.
So that was the distal marker which we could see while deploying the stent. So bile is draining very nicely and patient should get good relief from its symptoms. If you see the fluoroscopy, fluoroscopy. If you see the fluoroscopy image, the area near the clip of cystic duct, that much portion was having the stricture.
Yeah.
Yes, we can see a waste formation.
Yeah. So slowly within next 24 hours, slowly it will dilate.
Okay.
And it will open up the stricture more.
Okay.
And probably after this stent, looking at the stent, I feel it could be bismuth 2 also. So yeah. So probably it should drain both the systems. So we were right in putting only one stent. So no need for putting.
And in fact, the right hepatic artery was involved. So over a period of time, probably the right duct will,
anyway,
the right system will atrophy. If it is so it was right to put it in the left duct.
Okay.
Yes.
So now, okay. So that's it. And one more thing. This was the advantage of doing the case in supine position. So you could get proper anatomical images on the fluoroscopy.
Yes. The orientation is...
orientation more. Sometimes the cannulation becomes little difficult in this portion, but with some experience you can manage with that. Okay, I'll take out the stent now. Thank you. Thank you.
Yes. Thank you for the nice demonstration.
Thank you, sir. Chalo, thank you, sister. Changla ala. That was difficult stricture. You could pass the stent.
Shifting over to OT2, Dr. Joy sir will be starting the procedure. 36-year-old male came with complaints of multiple episodes of hematemesis since 2 days, history of esophageal banding done 1 year back for varices, history of blood transfusion 5 times in June 2025. Previous ogidoscopy report was suggestive of grade 4 esophageal varices with gastric varices. Esophageal banding was then done. Now plan is endoscopic variceal banding with glue injection.
स्टार्ट करें हम बोले डायग्नोसिस क्या है इनका
Over to Dr. Joy sir.
Hi, good morning everybody. So this is a case of portal hypertension. Is history of banding. So we are just So we are into the esophagus. You can see the varices here. So these are pretty large varices.
Yes. Good morning, Dr. Joy.
Good morning.
Dr. Makarand here.
Good morning, Dr. Makarand.
Yes.
So I am going, we'll have a full assessment first.
Yes, yes.
Yes, you can see the watermelon appearance also
Yes,
at the
yes.
antrum.
This is portal gastropathy.
Yeah, it is suggestive of PHG, portal hypertensive gastropathy. You can see the classical appearance of a rind of a watermelon.
Yes, yes.
The red streaks in the white background.
Yes. That is vascular ectasia, no?
Yeah. So that is called yeah. the duodenum here.
Yes.
A2. Mm. Yes.
Fundic varices.
Yeah, yeah. This is the isolated gastric varices. They are not in continuation with the esophageal ones.
Yes, yes.
Yeah. Good one. Take one. You'll have to glue up dalo.
What is the plan? Now, this is a case of esophageal varices with isolated gastric varices.
Isolated gastric varices should be treated. So here we would be gluing the isolated varices. Yeah, both would be better.
This is GOV1?
No, this is not GOV. This is IGV, isolated gastric.
IGV1.
Yeah. Because this is on the fundus and I think it is not in continuity with the esophageal varices. Here you can see the esophageal varices here.
See the clear red line.
Yeah.
Now, when a patient has both gastric and esophageal varices, which do we treat first, whether it's gastric or esophageal?
Gastric first.
Yeah. Both are separate.
So I'll go for this first.
Yeah.
Both need to be done.
Yes, sir. Mic.
Yeah. I'll give it to him.
Mic.
Yeah.
Always a tough job.
Blood.
Both for an endoscopic and also for our scope. So be very careful.
Yeah. Love.
So once you put your sorry, am I audible, sir?
Yes, yes. Now you
So
are-
as I was saying, glue injection is always difficult, both for the endoscopies as well as for the scope. So there are high chances of damaging your scope. Now before I put the needle, I could easily do this maneuver. But once the accessory goes inside, the movement becomes little compromised. So I will not be able to do the J maneuver that effectively. So you have to be mindful of that. Scope पकड़ाया जाता, हाँ घट्ट पकड़ाया था, हाँ घट्ट नहीं डाव्या हाताने घट्ट पकडा, हाँ हल्ला नाही पाहिजे अजिबात स्कोप. And your assistant has to be very alert. हाँ सोडू नका needle. एक मिनिट हाँ needle out कर पूर्ण. Yeah. Now using the scope. नाही रे glue. जोडलं. NS ठेवून दे हातात.
NS तयार ठेव.
So I'll insert the needle inside the varix. How can inject fast. Needle. Bas. Needle back. Now I'll just go away. I'll not do any suction. Soda scope.
Yeah.
I'll keep the needle sufficiently away from the tip of the scope and I'll pull out everything. Scope soda. Thamma. So if you see, he has cut the needle tip. So we are compromising this needle, but that is to save the scope from getting damaged.
See what he has done. He has injected the glue, then he has flushed it, and what he told yesterday that we should not do suction, which could damage the scope. That precaution has been taken. And sir, what is the amount of glue which you inject at
half
one?
cc. Depends on the size of the varix. Since this varix was not very big, we have injected half cc. You can inject 1 cc also, but at one point you should not inject more than 5 ml. So that is the dictum. So the chances of embolization are there. That you should be careful about that.
Dr. Mandar?
Yes, sir.
Are there any other agents which can be injected other than cyanoacrylate glue?
Endoscopically, no, sir. I haven't done anything.
Yesterday, Dr. Taklakar was telling some new
For
agent.
fundic varices, you don't use sclerosant.
Okay.
Only glue. Now the scope is ready again. I'll go inside and check.
Can you do glue injection in the gastric varices and banding at the same time?
Yes, you can do. But you should tackle the fundic varices first. Because once you put the band on esophageal varices, then passing the scope again becomes very risky. That's why you should, even if you find bleeding esophageal varix and there are large gastric varices, you try to glue the gastric varices first. Okay, so there is no bleeding. Some glue has come out because the varix is not. Now probably some glue might have gone in this varix also. So before loading the second syringe, I'll just feel that this varix with the needle. If the glue has gone in this, then this vessel also may become solidified. In that case, we don't have to inject glue in that. Pakda, needle.
And you will assess the firmness of the.
Yes. पकड़ा आता घट्टा पकड़ा घट्टा परत बघतो ना नाही काय वाटतं आधी what do you feel? Yeah, we need to put. This is solidified. This is solidified. Ghe. Oh.
So we'll be injecting glue in the next one as well.
So as we saw in the beginning also, this vessel was bigger.
Yes.
So are you going to take 1 ml or half ml? Yes, some glue has gone. From the previous injection, some glue might have gone there. So I think looking at the size, half ml will be enough. It's not very big. It is bigger compared to the first vessel, but it's not very big. Half ml would be enough.
Mandar, and in which varices would you decide for endoscopic EUS guided coiling and then glue? And what is your experience about it?
1 minute. So if the varix is very big and if you find the intramural portion of the varix is bigger, in that case we have to go for glue, coil plus glue. Pakada.
Here for the beginners, we could see that Dr. Mandar, he was definitely focused on gluing the varices, but a lot of focus was given on saving the scope.
Yes.
The needle. Here, there. So now I'll be pulling the scope, pakada scope. Inject, fast. करना बस बैक needle back So sometimes you will find bleeding after the glue is injected.
Yes, yes.
But you don't have to worry about that. Eventually that bleeding will stop. Same thing I'll repeat again. I'll bring the needle sufficiently out of the scope and I'll pull the scope out. And he'll cut the needle tip.
Will you do banding also?
Yes, sir.
Yes.
Is this a case of rebanding or primary?
Yeah. He has been banded before.
So he might have got fundic varices injection also before. That's why there is no much bleeding.
Generally, sir, but fundic varices recurrence will not happen.
No, he was banded around 1 year back, and that time there were no gastric varices.
Sometime that can happen, sir. Once you band the esophageal varices, the pressure will get further downwards, and that can increase the fundic varices.
Yes, yes.
And generally, fundic varices after you do glue injection, they generally will not recur.
Yes, yes.
Esophageal varices are more notorious for
yes,
refilling.
Dr. Makran, now we'll be doing banding also in the same case.
Yes, yes.
So now I'll just go and check again. Band kadun deva. Yeah.
So Mandar, are you going to open another needle to check the firmness of this?
No. We just want to feel the. But I think I've done a good job.
Yeah.
So no need to. And as I said, the vessel, the varices were not very big, so that glue must have taken care of that. So instead of wasting more time, I'll proceed with banding.
Yeah.
Mandar?
Yes, sir.
If accidentally this glue entered in the channel, can you wash with acetone? That is
Yeah, we keep everything handy, but if it goes in the scope channel, then Bhagwan hi hamare riksha kare.
Acetone is the agent, I think.
Yeah. But it's very difficult to clear that.
Yes,
Acetone, basically, if some part of the glue gets comes on the tip of the scope,
yes,
there acetone helps.
Okay.
You can immediately wash that thing out. That can prevent the damage of the lens tip.
Yes.
But if it gets into the channel, it's very difficult to clear that because it will solidify within seconds.
Yes.
That's why your assistant has to be really good.
Yes.
So everything depends on your assistant. No.
So I think it is better to give the scope in the hand of assistant, and you should get the role of assistant.
No. It's not that simple also.
It's not that easy.
Yeah. Even your role is also equally important.
Yes.
I think, sir, we have already shown banding one case.
Yesterday.
So if you want, you can shift to the other OT.
Yeah, that we can.
If it is ready.
We'll shift to the other OT, Makran, because banding has been already demonstrated yesterday.
Yes.
So Dr. Praveen will be showing PD stenting in the next OT. So
Yes,
we'll
sir.
shift over there.
Yes.
Shifting to OT1, procedure by Suryavanshi sir. 35 years old male, complaint of burning type of abdominal pain since 14 days, chronic alcoholic since 15 years. UAG abdopelvis suggestion of chronic pancreatitis with pancreatic pseudocyst in head of pancreas. CECT abdopelvis was done, suggestion of body and tail of pancreas appears atrophic. Dilated MPD of diameter 7.5 mm with few calcifications. Thin walled cystic lesion measuring 5.2 by 5.9 into 6 cm noted in head region of pancreas with MPD communication. Patient is now posted for PD stenting. Over to Suryavanshi sir.
Hello.
Hello.
Yes, Makaran.
Praveen.
So this is another interesting case, that alcoholic patient with recurrent episode of acute pancreatitis went into chronic pancreatitis. Now having pseudocyst of 5 centimeter,
Yes.
very close proximity of the pancreatic, main pancreatic duct. And so most of the time these are the non-necrotic cyst which
Yes.
are communicating in the main pancreatic duct. So the cyst which is, there is no necrosis at all.
Yes.
Okay. And if it is not resolving, that means there is a ductal communication.
Yes.
So otherwise there is no reason why cyst is not resolving. That fluid is not getting reabsorbed.
Yes.
Second is, another thing is that which is required is there is a ductal obstruction.
Yes.
So both things are required for a cyst to remain persistent.
Yes.
Okay? There has to be communication and there has to be ductal obstruction. So in these cases what we do trans-papillary drainage of this cyst.
Okay.
So
yes.
it helps not only just to drain the cyst, but also it relieves the ductal obstruction, whatever is there in the proximal portion of the pancreatic duct.
Yes. Yes.
Okay? So it takes care of both the issues. If you do just cystogastrostomy, then what happens? You are draining the cyst, but you are not relieving the ductal obstruction.
Yes. Yes.
Okay? So in such cases, we prefer to do trans-papillary drainage of the cyst and the decompression of the main pancreatic duct. Can you see here on CM?
No.
We have already
Yes,
cannulated
Yes.
main pancreatic duct.
Yes.
And this guide wire and even contrast is not going beyond the body of the pancreas.
Yes.
That means that the tail of the pancreas is also stricturous. It is tightly stricturous, and even contrast is also not going. Screen. See, now I am injecting contrast.
Yes.
See, that's all. And there is can you see at the head there is a communication?
Yes.
Ek minute. See, can you just on the screen at 11 o'clock position, there is a track going toward the cyst.
Yes. Yes. Yes.
Can you appreciate?
Yes. Faintly it is seen.
See, now inject, and you just keep observing. Inject.
Can you make the picture dark?
There is a track going upward.
Yes. Yes.
Okay. So that is the इकडचा घे बरं. So what we'll do here now, we'll do zebra tuck. We'll do wide sphincterotomy.
Yes.
इकडचं टाकून बघायचं.
Praveen, what is the difference in Terimo guide wire and zebra guide wire?
Terimo is a hydrophilic guide wire.
Yes.
And it is the tip is usually very it's a short tip, and we can torque this guide wire very comfortably.
Yes. Yes.
Okay. So for the cannulation of the difficult strictures or some difficult turnings in the common bile duct or pancreatic duct can be achieved by Terimo guide wire easily.
Yes. Yes.
It is not an exchange guide wire. So
Okay.
Terimo guide wire is typically comes in 250 centimeter length, and all these exchange like zebra guide wire or the Visi glide by the Olympus, they are more than 450 centimeter.
Yes. Yes.
Okay. So they are the exchange guide wire. They are more stiff
Yes. Yes.
than the Terimo. Screen.
Length of these guide wires are very excessive, I think.
Length?
Length-wise, they are very excessively long.
Yeah, 450 centimeter. Exchange.
Okay.
Yeah,
Okay.
there are two, like zebra, these are the exchange. We exchange the instrument, equipment, or
Yes.
stent over this guide
Okay.
wire.
Okay. Okay. They reach up to assistant
Yeah.
compatible.
So whatever scope length is there,
Yes.
equal length has to be there outside.
Okay.
Then only you can exchange it.
Yes. 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 Yes.
Okay. So I will do sphincterotomy. So whatever obstruction is there, that will be relieved. So this is pancreatic sphincterotomy. So I
Yes.
am doing at 1 o'clock position. Can you
Yes, yes.
appreciate this?
Yes, yes.
And it is, you can see it's very fibrotic.
1 o'clock, is it the fixed position, Praveen, or if there is the previous papillotomy, the position will drop to 3 o'clock position?
No, in that then you need not to do it. No?
Okay.
Whenever you are doing for the first time, you should do it at 1 o'clock position.
Yes, yes.
It's very fibrotic. Take enough. Stent. 5, 7. Yeah. So for me, this patient, this position is also not very stable. Scope position. So whenever there are large cysts in the pancreas,
Yes.
then this scope, having good position in the duodenum is always challenging. It always tries to fall back into the stomach.
Yes, yes.
So now we have series of more than 30 patients which has been treated by the trans-papillary drainage.
Okay.
So the prerequisite for this is again there has to be communication with the main pancreatic duct.
Yes, yes.
And second thing, there should not be any necrosis.
Yes, yes.
This should be clear cyst.
Yes, yes.
Can you see CT scan here? I think CT scan has been shown, no?
No, no. It is not shown.
Here देखो.
Can you get the closer view? Can you focus on it?
Yes. 1 minute, I will show.
Ah, yes.
देखो. Cyst. 1 minute.
Ah, yes.
Once stent is deployed, I will explain. Or Dr. Joy can help me. Yeah, they show the pseudocyst. Is there? Yeah. Yeah. No, the camera is there.
Sir, online there is a query that is there any course, hands-on course available for general surgeons to do endosurgery?
Yeah. Tomorrow we have, no? From tomorrow, they can join ASI course. The fresh course will be launching from the month of August. So they can join that course. In that course, what we have planned at ASI, that there will be initially lecture series by the stalwarts. So they will be, trained to, theoretical part of the diagnostic and therapeutic endoscopy. And then there will be a hands-on training on mannequins and the animal lab at ASI head office. And after that, they will have to attend any center of excellence across the country minimum for 2 weeks, where they will get actual clinical exposure. And after that, ASI will award them fellowship certificate. So I will request those who wish to continue or learn endoscopy, they can join that course. Deploy. Okay.
Yes,
So
yes.
this is pancreatic stent. So usually pancreatic stents, they are a little different than the biliary stents. They are a smaller French, like 5 French, 7 French. And second thing, they have multiple side openings throughout the stent.
Yes.
So whatever side branches are there, they are draining into the main pancreatic duct should get drained out That's why there are multiple side openings throughout the length of the stent.
Yes, yes.
Okay.
So here we are seeing the CT scan. CT scan दिख रहा है? This is the venous space. This is the portal venous space. You can see the heart here, and you can see.
Very nice demonstration, Praveen.
Yeah, thank you.
Fluent and nice.
We treat a lot of pancreatic ascites, pancreaticopleural fistulas.
Yes, yes.
Just with pancreatic stenting, everything get dried up just.
Dried up, yes.
Dr. Joy is explaining you CT scan.
Okay, okay. Can you hear me? No, no, we cannot hear you, Dr. Joy. Please take the mic.
Here you can see the portal face of this patient CT. The heart is seen here.
Yes, the picture is slightly blurred.
Focus. Clear karo. Hello, hello.
Hello.
Yeah, we are trying to rectify it.
Okay, okay.
The camera is a bit far away. It's trying to bring it closer.
That might be the reason.
Hello. Hello, Makarand, can
this
you
is
hear
a very
me?
good CT scan actually to read.
Dr. Bhaskar, sir.
Yeah. Sir.
Dr. Joy is explaining the CT scan. Just 1 minute. Huh?
Yeah.
Yes.
So this is the liver, you can see. As you come down, you can see the negative. This is an angiofilm, so there is no oral contrast given. There is fluid in the stomach. This is the spleen here.
Yes.
As you come down, you can see the portal venous confluence here.
Yes.
And then the portal vein forms, and thereafter, here you can see this lesion.
Yes.
This is the pseudo cyst, which is opposing the posterior wall of the stomach.
Yes, yes.
There are, you can see vascular channels in between.
Yes, yes.
So here it is lying in very close opposition with the stomach.
Yes, yes.
Yeah. This is in the head exactly. Here you can see some part of the uncinate of the pancreas here.
Yes.
And this is the head. The lesion is in the head of the.
Yes, yes.
The pseudocyst is in the head of the pancreas. Now as we come up, we'll try to trace the tail, but I think it is an atrophic pancreas. So
endoscopic cyst gastrostomy was another option. Praveen?
See, again, if you can see here, there are many vessels here
Yes,
anterior
yes.
to the cyst.
Yes,
So
yes.
this patient has already, portal hypertension, splenic vein thrombosis.
Okay, okay.
That's why all these, you can, if you can see varices here,
Yes.
can you see varices here around the cyst, at the lower border?
Yes, yes.
Here
all
also,
these are varices.
yeah.
All these are varices here.
Yes, yes, yes.
Normally, you don't get vessels on the posterior wall of the stomach.
Yes.
But these are because of the varices development, splenic vein thrombosis, these varices are there. And again, as we also saw in the pancreatogram, we could not delineate the tail of the pancreas.
Yes.
On CT scan also, pancreatic tail also is not appreciated.
Okay.
So it is a like completely atrophied pancreatic tail, and stricturous, and the almost head of the pancreas is replaced with the pseudocyst.
Yes, yes,
Even pancreatic head parenchyma also cannot be appreciated on the CT scan.
Yes, yes, yes.
Okay.
here you can see the splenic
Splenic
in
vein.
the distal region. Thereafter, here it is all replaced by collaterals.
Yes, yes.
And some beautiful collaterals seen here also.
Yes, yes, yes. Definitely.
Okay, thank you.
Nice demonstration, Praveen.
Yeah.
Nice explanation.
See, all this is very important. Just we have
Yes,
to be,
yes.
good radiologists.
Yes,
you should
yes,
able
yes.
to read your own CT scan images. You should able to decide what is good for the patient, whether endoscopy or
Yes.
laparoscopy. That's why you should have like that, like Roman emperor. They were equipped with so many, armamentarium.
Yes.
So as per the requirement, they used to use that weapon in the war field.
Yes, yes.
Okay, same way now in today's days era, we must equip ourselves with many more armamentarium, whether it's a laparoscopy, endoscopy, or robotic surgery, what more is there on in pipeline.
Yes,
So
yes.
we must train ourselves for the every possible technology to offer best possible treatment option to our patient.
Yes, yes. And
ठीक है?
yes,
We
yes,
should be the master of science, not just one technology.
yes,
That's
yes,
what
yes.
I believe.
Correct, correct. And this was the wonderful opportunity,
Yes.
this
yes.
conference.
Thank
you
you,
have created it. Thank you, thank you.
Thank you.
We'll shift to OT3, colonoscopic procedure by Advai sir.
Yes, yes.
A 55-year-old male came with complaints of pain in right upper abdomen since 2 months, weight loss of 7 kgs in 2 months, and is a known case of hiatus hernia. His blood investigations, HB was 12.1, TLC was 17,000, and platelets 7,61,000. ESR 10, LDH 126. Stool routine was suggestive of 1 to 2 pastilles per high power field. Stool for occult blood was negative. CCT abdopelvis suggestive of long segmental circumferential wall thickening of terminal ileum, IC junction, cecum, and ascending colon with multiple mesenteric lymph node, with few of them showing necrotic areas. Features are likely suggestive of abdominal cox. Now patient is planned for colonoscopy with biopsy. Over to Dr. Advai sir. Over to you, sir.
Hello, Advai.
Yeah, you're audible, sir.
Yes, yes. You are audible. Yes, yes, yes. You are audible. Hello. Hello, Advai. आपला आवाज जात नाही तिथे. हॅलो.
Hello.
Yes, yes, yes.
Sir, now we had just heard the history that this gentleman has a history of weight loss of around 7 kgs in 2 months.
Yes, yes.
And pain in right upper abdomen.
Yes.
So the purpose of this case demonstration is by public demand. They wanted to see how the colon has to be negotiated.
Yes, yes.
So first we will start with the, this is the anal canal, we will go straight here.
Yes.
Colonoscopy doesn't have any fixed maneuvers, but important thing is the torquing and pulling out the scope to straighten the scope. These are 2 or 3 important things.
Yes, before proceeding, can you tell about the preparation in partially obstructed bowel?
So what we do is typically is we give them split preparations.
Yes, yes, that is important.
So that is the norm nowadays. So half liter of the preparation should be given, half of the preparation. Now there are various preparations. Some come in 1 liter, some come in 2 liters.
Yes.
So what we do is half of the amount of the preparation is given 1 day prior in the afternoon.
Yes. Correct, correct.
And the patient has light diet.
Yes.
And at night, and next day morning, early in the morning, we give the remaining amount of preparation.
Yes, yes. I have seen 2 patients who have perforated because of wrong preparation technique.
In this way, what we can do is this is a controlled preparation. If the patient has some problems, we can intervene earlier.
Yes, that's why good ultrasound and diagnosis is necessary before.
So now we are trying to negotiate the sigmoid,
yes,
rectosigmoid junction. Now here, patient is in the left lateral position and given TIVA, total intravenous anesthesia. So I think we are at the splenic flexure.
Yes.
Okay. Now here what you do is I would typically pull back my scope a bit, do some suction, and try to negotiate the splenic flexure. So here, right torque or left torque will help me to find out the lumen. Most important thing is, now see what I am seeing this curve, and I know that my lumen would be on the right side.
Yes, yes.
So what I would do is, I will give a right torque here, but still I am not able. Important thing is no blind pressure to be given on the colon.
Yes, yes.
So that there is no injury. Perforating the colon is quite a deliberate thing which you do. Otherwise, easily the colon will not get perforated.
Yes, yes.
So now, by giving adequate right torque, I am again into, now my lumen is here. Now here what I would do is, I would ask my assistants to give pressure in the left iliac fossa.
Yes, yes, correct.
इकडनं दाबास खालून इथे हां. And the most important principle is ki don't worry if your scope falls back. You can always go, don't panic, and gradually you can find out the lumen.
Yes, yes.
Now, again this has happened. I am again fallen back across the same stricture while instructing my assistant. But now it's okay.
Is it advisable to fully anesthetize the patient or keep some partial anesthesia?
Sir, I typically do all my colonoscopies under propofol anesthesia.
Okay. Yes.
But most of the people, they do awake also.
Yes, yes.
But it is quite uncomfortable to the patient and bad mouth publicity about the procedure. So I don't want that. The patient should be very comfortable post procedure. And also, if the patient starts shouting, in your beginner's day, you will also get panicked.
Anesthetic standby with fentanyl or Fortrin is my protocol in hospital.
Fentanyl or propofol? Propofol I would prefer.
Okay. Tall, thin-built patients, they are very difficult.
Yeah. This gentleman is also very thin-built.
And tall.
Because there are acute curves.
Yes, yes.
There is no mesenteric fat.
Yes.
So the colon loops on itself. And there is always a patient in whom you cannot complete the colonoscopy. So
Yes,
you
yes,
should
yes.
not worry about it. And this is especially for the beginners, and you should take help from some senior. And don't get panicked and try to. Yeah, that is what I was trying to tell. Even Dr. Mahadev sir has many times in his conferences, in live demonstration, has said, there are instances when I am not able to complete the colonoscopy.
Yes, yes, yes. Colonoscopy is more difficult than ERCP. That was told by Dr. Mahadev.
No, everybody, all the procedures have their merits. I would not say that, but I think every surgeon should do colonoscopy.
Yes, yes, yes.
Gradually, he would learn, attend some this kind of conferences where you get confidence. See, now I am also struggling here.
Yes, yes.
But
I think this is gamma loop of transverse colon.
No, sir, my scope is quite straight right now.
No, no. Internally it is looping with gamma loop. So in such case, I will change the position of the patient.
So that is one philosophy, that change the position of the patient.
Yes.
But I think I can manage. I have managed almost all the patients in the left lateral position, because it becomes very messy sometimes. See, now I am trying to advance into the transverse colon. Always come back and again go in, which makes your life easier.
Easier, yes.
And apply adequate amount of suction.
Suction, yes, that is the thing.
Suction is very important in colonoscopy. If your suction is poor,
suction and withdrawal is the colonoscopic technique. Yes, yes.
One-to-one movement, so probably it's unlikely that the scope is looped.
It is looped a bit, no doubt, but it is not getting reversed also.
Yes, yes, yes.
Now I am into. I have completed the transverse. See here. And then here we can see that there is a bit of narrowing of the lumen and edematous colon.
Yes,
Here
sir.
I would be very cautious not to give any undue pressure on the colon. Can you appreciate this?
Yes,
this,
yes, edematous.
This is edematous.
Have you entered in ascending colon?
Yeah, I am into the ascending colon
Yes.
now. अभी ना इधर pressure है.
Can you show the glow of light on abdomen of the patient?
So then that will expose the patient.
Okay.
And I don't want to do it because personally it's okay while doing it in your individual setup, but in a live transmission.
Yes.
Here I would clean my lens. Here there is almost obliteration of the lumen.
Yes, yes, edema.
Can you appreciate the edematous lumen?
Yes.
And from here, even if you take biopsies, it would be negative.
Yes.
So now what I would do is, there is some, can you pinpoint here? There was some opening.
Lumen is on right side.
Yeah. See, here.
Yes.
I am trying to easily negotiate across
Yes,
it
yes, wonderful.
without any undue pressure on the colon.
Wonderful.
But the entire segment is edematous.
Yes.
Till now I had not used my small wheel, but now I am going
Yes.
to make use of the small wheel a bit.
Yes.
Okay. Now I think
Cecum.
this is the cecum. Okay.
Yes.
And
no, we have lost endoscopic picture on the screen. Ah, yes.
okay, this is the appendiceal opening.
Yes.
So I am into the cecum now. So what is happening? I wanted to go inside the IC wall because the CT scan is showing across, negotiate the IC wall. Here I think, here.
Yes, yes. At 11 o'clock.
Yeah.
Dr. Advai, what are the tricks to negotiate the IC wall?
Sir, first is you need to stabilize your colon very deep into the cecum. Identify the location of IC valve. See, now here I am stabilized my scope. I am not doing any maneuvers, my hands are free. And I am appreciating that is at 11 o'clock there might be the opening.
Yes.
So what I will do, I will go there,
That
kiss
is the
this.
one lip, yes.
Yeah, go very near it. It is also called, sometimes it is called as kissing the IC valve.
Yeah.
And then inflating gently.
It is also edematous.
Yeah, it is also edematous. But there is no mucosal abnormality.
No.
Yeah.
There are no ulcers.
Yeah. But it is getting difficult to negotiate.
Yeah.
But so finally, I think I am across.
Yeah,
Yes,
yes, you're inside.
definitely.
You're inside.
But
Yes.
so this is the terminal ileum.
Yes.
Okay, you can appreciate the change in the mucosal pattern.
Yes.
This appears to be cuboidal, although everything is the same, but the vascular pattern changes.
If you spray water and magnify, you will find a villi floating in it.
The colonic preparation is quite good,
Yes.
so no need to instill water here.
No,
and
just for demonstration purpose. of
Pani
the
taka.
villi.
I think here our laparoscopy colleague would come into the play, and the patient might be, I think a diagnostic laparoscopy has been mandated here. If there are CT findings of necrotic nodes and narrowing colonic.
Thickening of ascending colon.
Yeah, thickening of ascending colon. So,
What is the age of the patient?
59.
so I am washing it here.
55.
Yes. No, wonderfully seen.
See, now you
Yes,
can
yes.
see the mucosal pattern.
Yes. That is the
Okay.
ideal mucosal pattern. You can magnify and see also. Yes.
Makaran convinced?
Yes. No. That was for demonstration only. I was.
I will try to go further deeper into the terminal ileum if it is possible easily.
Yes.
Yeah, so I have gone in. here. So I cannot find any ulcers deep into the terminal also, terminal ileum also.
Yes.
So we are now coming back. Okay.
Yes, yes. Sure.
So are you all convinced that there was no any ulcer found?
Yes, yes.
Of course, the examination has started now while coming back.
Yes.
So now I am into the cecum again. There are few cecal diverticuli.
Yes.
I would show them. So this is the appendiceal opening, and there are some few cecal diverticuli here at around say 8 o'clock or 7 o'clock. Okay. So and coming back, but the ascending colon is thickened and edematous, no doubt about it. But as such, there is no pathology, intraluminal pathology.
Yes. Are you going to take the biopsies from the edematous part?
Sir, it would be negative, no doubt.
Non-specific colitis it will be.
Yeah. And unnecessary delay the further treatment of the patient.
Okay.
I think he should be subjected to diagnostic laparoscopy.
Yes.
That would be better.
No, internally, that doesn't, mucosa seems to be normal.
Normal, yes. So the most important thing is to use your torquing movement.
Yes.
So this is the right torque, this is the right torque, this is the left torque.
Yes.
And try to suck in between, just like yesterday I told, suck the segments which you have already inspected, so that the patient doesn't have bloating post-operatively. Makran sir, because of propofol and colonoscopy done very patiently, most of my patients, when I meet them post-procedure, they would ask me, sir, आमचा number कधी लागणार आहे? So for the beginners, I would suggest that you should do colonoscopies, but you should not make it an ego issue to reach the terminal ileum.
Yes.
And don't be forceful on the colon. Try to suck away whatever is the liquids, ileal efflux, which we can say, so that you don't miss any ulcers. Clean your lens regularly.
Yes.
And gradually you can come out. See, this is the hepatic impression, I think. See, can you appreciate, Makran sir?
Yes.
The bluish tinge?
Yes. Is it splenic impression?
Yeah. For the delegates who want to start colonoscopy and take biopsies, I would like to mention that there are two lengths of biopsy forceps. One is colonic length, which your seller will never tell you, and invariably you will end up buying a gastroscopy length biopsy forceps, and during colonoscopy you are stuck. So always mention him that whenever you send me biopsy forceps, it has to be colonic length.
Yes, it is more than 230 centimeters.
Yes.
And gastric is 180 centimeters.
Also the needles and the snares, they also come into two lengths.
Yes.
So you take all the accessories of colonic length. So we are almost completed this case.
Yes.
Any questions?
Advay,
yes, sir.
Whenever you are doing colonoscopy, is it necessary that you have to do J manure to say that it is complete, or it's not necessary?
No. Sir, can do J maneuver for demonstration purposes, but what typically I would do is, I would inspect the anal canal in a straight position, and there are almost grade 1 hemorrhoids.
And it is very unlikely that you will miss anything.
In a straight position also, but here the rectum is, it is a dangerous maneuver and not recommended for doing in every patient. Okay?
Yes, yes.
Sir, high tea and breakfast is being served outside. Please join us.
Go past up to turning line.
काढ आता काय गरज नाही पॅन्क्रियाटोस्कोपी हां हां त्या सिटी स्कॅन लावाय त्याचा हां हां झेब्रा टाकून घेऊ का आधी हां घे हॅलो
हां प्रवीण
Yes. Hey, welcome, sir. Welcome. Please come. Please. Thank you.
Shifting to
Thank you so
OT1.
much, sir. Thank you.
Procedure by
Pancreatic
Dr.
ductal
Praveen
lesion.
Sivanji, sir.
Doing pancreaticoscopy.
Good morning, Dr. G.V. Rao, sir. Hello, Praveen.
Yes, yes, yes.
G.V. Rao, sir, has come.
Yes, the star of the day is here today.
Yes, yes, yes.
Yeah, now. He has reached, with a lot of efforts. Yesterday he was there in Delhi. Whole night he has traveled to reach Aurangabad.
Okay.
Yeah. So thank you so much, sir. So this last case I will be demonstrating. This patient is having, on chronic pain in abdomen, and on CT scan there is a dilated pancreatic duct. We can see already I did the pancreaticogram, and there is a lesion, nodular lesion in the main pancreatic duct at the junction of the neck and body of the pancreas.
Yes, yes.
Okay, so what we have planned is we'll do pancreaticoscopy and we'll take biopsy of that nodular region in the main pancreatic duct.
Yes.
If possible, and we'll stent the main after that. So if biopsy is not possible, if you are not able to negotiate this pancreaticoscope, then we'll take at least brush cytology, from the main pancreatic duct. So we'll attempt first for the pancreaticoscopy to take biopsy first.
Yes. Praveen, what is the specificity of breast cytology?
Pardon?
What is the
sensitivity?
Sensitivity, yes.
See, now it's pull. Ek minute.
Yes.
See, if you do under vision with pancreaticoscopy, it is like same like any other biopsy.
Okay.
Okay, but if breast cytology, definitely it is almost 40% only.
Okay.
So this is now our same cholangioscope. We are trying to negotiate into the pancreatic duct. Yes. Can you appreciate?
Yes.
So this lower part is normal. So it's difficult. From the stricture part, it is dilated. Can you appreciate?
Yes.
So at the, see now I am inside the main pancreatic duct.
Yes.
See, are you having?
Yes, wonderful vision.
Yeah. So this is acute.
See, this is.
Yes.
Can you hear me?
Yes, yes.
Yeah, this is not that very easy as Praveen is showing it actually. You understand? To negotiate this cholangiocarcinoma across is absolutely requires a lot of expertise. And what is shown is right actually. Even by looking at the stricture, grossly we should be able to make a diagnosis basically, because we as surgeons are better placed than the gastroenterologists. So even by looking at the stricture, I think we should be able to make a gross diagnosis. But obviously, what is beyond that narrowing cannot be seen.
Yes.
So what he's saying is absolutely right actually. He's got some initial picture that is beautiful actually.
Yes, yes, yes.
That looked like a benign stricture, the first impression.
Yes, yes, yes. Yes, now.
See that?
Can you see this now stricture here?
Yes. Grossly, it looks like a benign stricture. You understand? All the urologists who see this urethral stricture, no, it is typically like a urethral stricture.
Yes, yes, yes. Yeah, so what we'll do, we'll put, like minimum 7 French catheters.
Yes, 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 absolutely.
In the pancreatic, so that, there will be dilatation. I don't think we should take biopsy and
this does not. Right. This looks grossly benign. See, we can see that actually. See, there is no ulceration, no just scarring actually. So beautiful demonstration, Praveen, actually.
See, this is the stricture.
It's not, and you're able to see the side branches also. You can see that actually.
Yes, yes.
Yeah.
Yeah, right.
Yeah.
So that actually again we look for some IPM or something of that sort. There is no mucinous material here.
Exactly.
You understand? All these are the gross features that we look for. If there's any mucin in the duct, yes, then we think about some side branch IPM or something of that sort. This looks absolutely clean actually.
Yeah, it's a benign stricture related to the pancreatitis.
You want to dilate this, Praveen, or you want to put a stent directly?
And I think we don't get any dilator. This is, I think 7 French should go.
7 French should go in very comfortably, yeah. Yes.
So I will take out the cholangiocarcinoma and will stent this patient with the 7 French pancreatic stent.
Yes,
Attack screen. Attack. Attack. So this is how we improve, it helps to, if at all there are any neoplastic lesion, then we can, diagnose them, we can take biopsy, breast cytology, so that the accuracy yield improves, and we can pick up this lesion at early stage. Not, really, because that's the only way to give cure to these patients. When you diagnose them at early stage.
Absolutely.
So this is how surgeon endoscopy, we can, give complete comprehensive care to our patients. If, we are master of everything.
See, the biggest advantage is actually you are able to decide whether this patient is going to get benefited by endoscopy or by surgery. See, we don't have to do, this patient is benefit from endoscopic treatment. But suppose if it is very tight stricture, I think Praveen would have straight away said, okay, take him for surgery.
Exactly.
So actually that is the advantage. Instead of subjecting these patients to repeated stenting where they are not beneficial, I think this sort of a department which has got surgeons doing advanced endoscopy work, it's not done by routine endoscopy centers, but advanced centers. I think it's going to make a lot of difference actually. And having an endoscope or a colonoscope in the theatre is a must in current day clinical practice actually. It's a must. See, there are a lot of things that can be done. Actually, I keep saying the same thing. You're not competing with gastroenterologists. We are trying to compete with the quality of life of the patient right now. So we are doing procedures inside the theatre just to improve the outcomes. Not for any this thing actually. So
wonderful
10 centimeter again. 10.
Really wonderful thought.
Sorry, we didn't hear you.
This was a really wonderful thought you have given.
Cost?
No, thought you have given.
Right. This is actually, I mean, I'm totally convinced. See, the amount of work, suppose if you properly do, the amount of work that you can do in the theatre is more than what some of the gastroenterologists can do outside.
Yes, sir. Yes, sir.
See, and we don't have to understand, actually we can show that this is how the quality of procedures can be improved. And see, we keep seeing patients actually who are repeatedly stented. See patients like this actually. For 20, 30 years, they keep stenting, and at the end, by the time they come to us, they end up with secondary, you understand, extrahepatic portal hypertension because of venous thrombosis.
Yes,
and then surgery becomes difficult for us.
See, Makar, since there is a solitary stricture which is benign at the head of the pancreas, so this is the indication for endoscopic therapy. If there would have been multiple strictures and the chain of like appearance like that, I would have subjected this patient for the surgical management.
Absolutely, yes, Praveen. Yeah. That is what we want actually. And a significant proportion of these patients come from low socioeconomic status.
That's right.
They
That's
cannot
right.
afford to have multiple procedures done.
Exactly. So we have one patient in Aurangabad itself, a doctor's son, surgeon's son. He has been treated at multiple centers, not less than 15 times. And still there is no relief.
I think we should, at some time, I think centers like Praveen, they do this actually, wherein case comes like this. You can always sit and discuss the pros and cons of different procedures. If the patient is not agreeing, that's a different issue, but we have to tell them.
See, at the stricture side, our stent is just occluding the lumen.
Yeah, absolutely.
So this is a perfect size stent.
Perfect stent. Perfect stent actually. And I think, see, basically not only this, you should look at Praveen's hand movements. He is not using too much of hand movements. You understand?
Yes, sir. Yes.
Yeah, same thing. Suppose you see some of the gastroenterologists doing, they try to, you understand, so much of force is used to do those unnecessary movements actually.
That's
yeah.
So these sort of things are very, very important. It not only damages the scope, but also the amount of, see, this indirectly gets transmitted onto the pancreatic duct.
Yes.
Exactly.
See, whatever we do, movement that we do, indirectly get transmitted to the pancreatic duct. So I think we have to be very, very gentle in handling these patients actually. And I've seen Praveen evolve over the years. My God, phenomenal evolution.
He is under Dr. GV's and Dr. Nagasha Reddy's guidance.
Phenomenal evolution.
Let me tell everyone that during my initial days when I came to Aurangabad, I went to AIG when it was there as a Medinova.
Medinova, right.
With my gastroscope, my ERCP scope, everything, I carried myself to their center. And I was fortunate to get hands-on training with my own scope at AIG.
Yeah, those days we did not have extra scopes for training. So
yes,
a lot of people like Praveen who came here came with their own scopes, trained themselves, and then...
I'm very grateful to them for,
no, but setting up an institution, see, unless and until you have some vision like this, Praveen.
Yes, sir.
So I'm just waiting for the day when Praveen is going to get MCH surgical gastroenterology
here.
And I want to come and see the department actually. I'm sure this is going to happen very soon actually.
Yes. So these are many ways to push the scope inside, stent inside.
Yes,
so always don't use this elevator to negotiate the strictures. See, this is how it has gone. Screen?
Yeah.
See, it has gone now.
Yeah. That is fairly good position.
See, yeah. See. So I will deploy it. We have crossed the stricture. Yes, deploy. Yeah. Biopsy for 7.
Praveen, are you pushing the stent with biopsy forcibly?
Pardon?
Are you pushing the stent with biopsy forceps into the lumen?
From the, it got stuck
Channel.
inside the
Channel.
channel.
Yes,
So biopsy forceps is the best instrument.
Yes, yes, yes.
Yeah.
I think some of you should come here and see this department. It's a full-fledged, advanced therapeutic endoscopy department, actually, the way it is laid up.
Yes, sir, yes.
What happened? Yes.
Yes, yes.
Okay.
Yes.
Screen.
Wonderful,
Okay.
wonderful.
So we have crossed that stricture part.
Yes, yes.
Okay.
Yes.
Yeah. Thank you so much.
Yes, wonderful demonstration, Dr. Praveen.
Shifting to OT2, procedure by Dr. Joy, sir. "56-year-old female came with complaints of difficulty in swallowing liquids than solids since 3 months, post-meal vomitings, nausea and post-meal retrosternal burning pain. Patient is posted for orgidoscopy." Over to Joy, sir.
आवाज नहीं जा रही.
Hello, Dr. Joy.
Yeah. Can you hear me?
Yes, sir, yes, sir.
Yeah. So this is a middle-aged lady who's been taken up for complaints of dysphagia. So first we passed the cricopharynx and you can see some secretions here.
Yes, yes.
Again secretions here, the esophagus seems to be dilated. OGD-scopy for this is clinically suspected to be achalasia, so an OGD-scopy was planned.
Yes.
So what do you expect in an achalasia on OGD-scopy? Are you planning to diagnose? The right diagnostic modality is a manometry. It gives you the exact pressures and the diagnosis and the type of achalasia. So what do you want to do on an upper GI scopy with achalasia? Since this lady is middle-aged, my first priority would be to rule out secondary achalasia. Like, is there a G-junction tumor which is causing this amount of dilatation? Here there is dilatation and secretions present. So now I am reaching the G-junction. I am insufflating air, but still
yes.
Yeah, there is a giveaway. Definitely there is a giveaway. So I'll just go ahead. So I am here at the pylorus.
Yes.
I'll do the J maneuver. suck out any fluid. And here you can see the flap valve.
Yes.
You clearly see the fundus. There is no evidence of any tumor or any lesion which is causing secondary achalasia.
Yes.
So you deflate the stomach and you come out. Here you can see the columnar junction.
Yes.
So the findings what we took was secretions present. It is more of a clinical, achalasia has significant clinical findings.
Yes.
Like the patient will classically tell you of one is dysphagia predominantly to liquids, solids would be more like with malignancies. Then they would have a classical nasal regurgitation.
Yes.
Which is very classical. They would say in the night they have classical regurgitation. On endoscopy, you can see a dilated esophagus passing G-junction, difficulty, negotiating it with difficulty. And then one thing what you can see is also look for some peristalsis. We'll wait for some time. Can you see some sort of, this is maybe an ineffective peristalsis. There is some segment causing peristalsis, but it is not propagating ahead. So that is it. We'll note our findings and we'll come out. The next investigation would be a manometry for this patient to type to find the type of achalasia.
Yes.
And confirm the findings.
Okay.
Yeah. Thank you.
Makran.
Sushil.
Hello, Dr. Makran.
Sushil.
So, Dr. Sushil. Now, with this, we conclude the session and we take a break for the oration.
Okay.
Dr. G.
Dilated
has arrived. He
esophagus,
must be coming upstairs.
secretions present.
So we stop the telecast from here.
Okay, G-junction
after the oration
negotiated with difficulty.
Yes, yes.
Negotiated with difficulty. Stomach normal. Duodenum D1, D2 normal.
Good morning to one and all present here. Welcome you all to second day of third ENDOSURG 2025, a dedicated event of endoscopy for surgeons. Today, we are really honored to have our prestigious guest, Dr. G.V. Rao sir, Director of AIG Hospitals, Hyderabad. Welcome you, sir. Now, I would like to request Dr. G.V. Rao sir to please come on the dais. Dr. Praveen Suryavanshi sir to please come on the dais. Dr. Musande sir. Dr. Mandar Doifode sir. I would now request Dr. Praveen Suryavanshi sir to introduce our orator, Dr. G.V. Rao sir.
Good morning. It gives me immense pleasure to introduce our second orator for the ENDOSURG 2025. Dr. G.V. Rao, Director, AIG Hospital and Asian Institute of Gastroenterology, Chief of GI Surgery, Minimal Invasive Surgery, GI Oncology, Robotic and Transplant Services. Dr. G.V. Rao is one of the India's leading surgical gastroenterologist. And the director of the prestigious AIG Hospital and Asian Institute of Gastroenterology, Hyderabad. The institute is certified as the Center of Excellence by the World Endoscopy Organization, the only one in India, and has been consecutively rated as one of the best gastroenterology center in India. The institute has expanded and commissioned a 1,000-bedded state-of-the-art tertiary care hospital, which is the largest single specialty gastroenterology center in the world, offering affordable care. Indian Institute of Gastroenterology is part of APAN, Asia Pacific Advanced Network, a non-profit organization that connects the research and education network of its member countries to each other and research workers throughout the world. Dr. G.V. Rao is the Chief of Surgical Gastroenterology, GI Oncology, Minimum Invasive Surgery, Robotic and Transplant Services. He has organized several national, international conferences, workshops, and is faculty member at all major gastroenterology surgery conferences. He has delivered 21 named orations, both nationally and internationally. He is the immediate past president of International Hepatopancreatic Association. He is the board member of Asia Pacific Endoscopy Task Force, Asia Pacific Endo-Laparoscopic Surgeons, President of Indian Association of Surgical Gastroenterology, past President, Society of Gastrointestinal Endoscopy of India, past President of IHPB India. He was awarded the Outstanding Young Person Award by Japanese International and the recipient of the Government of Parliament Gold Medal for his outstanding contribution to the field of gastroenterology. He has bestowed with the prestigious Dr. B.C. Rai Award in 2009 and more recently with the Economic Times Inspiring Doctor of India Award 2018, which acknowledged the architect of Healthy India. A jury member for the recent Pride of Telangana Award, Dr. Rao has received the Honorary Fellowship of Venezuelan Surgical Society, Philippine Surgical Society, Egyptian Laparoscopic Surgical Society, and the Fellowship of Royal College of Surgeons and Physicians, Glasgow. He is one of very few surgeons in the world with enormous experience in both minimal invasive surgery and the endoscopic surgery. Over 20,000 complex gastrointestinal surgeries and around 18,000 endoscopic procedures to his credit. He has pioneered several innovative surgical techniques and is one of the co-inventor of NOTES, that is natural orifice transluminal endoscopic procedures in the world for the first transoral endoscopic appendectomy. As a part of NOTES campaign, he has conducted many live workshops and is involved in the technology development for the NOTES. He played a crucial role in collaboration with the Indian Institute of Science, Bangalore, to develop an indigenous surgical simulator. He helped develop a robotic nurse system working with IIT Hyderabad, which is poised to assist at rural center to connect and coordinate with tertiary centers to decrease the morbidity and mortality in places inaccessible for healthcare services. He is actively involved in designing development endoscopic accessories and stents which are economical and are in clinical usage. He is on the editorial board of 4 peer-reviewed journals and has more than 256 publications in national and international journals and authored over 10 chapters in the textbooks of surgery and endoscopy. He is associated with the Asian Healthcare Foundation, which is dedicated to the health needs of the rural population of India. As a part of rural health program, screening program were conducted for early detection of gastrointestinal diseases and to promote the awareness regarding prevention in the states of Andhra Pradesh and Telangana. The research facility has several breakthroughs in the gastroenterology. He is a part of the team responsible for identification of mutation in pancreatic diseases and is acknowledged worldwide. Islet transplantation is one of the emerging modalities for the treatment of diabetes. He was the principal investigator in the Government of India approved IBT ICMR research experimental work, which was successfully completed and is now approved for clinical implementation in India and being successfully done. So ladies and gentlemen, it gives me immense pleasure and pride to introduce Dr. G.V. Rao as an orator for the ENDOSURG Oration 2025. Thank you so much, sir, for being here. Yesterday he was in Delhi attending one very important conference, and whole night he has traveled to reach Aurangabad today early morning. So it shows his commitment, determination and passion, just not for the surgical services, but for the education and spreading whatever he has achieved in his last 35 years of surgical gastroenterology. So thank you so much, sir, for accepting our invitation, and truly we are honored to have you here for this oration. Thank you so much. So, Dr. Rao.
Good morning. Thank you. I am humbled by Dr. Praveen Suryavamshi's introduction. Thank you for having me here, and thank you for allowing me to see the rise of Praveen Suryavamshi over the last 2 decades. Phenomenal transmission that he has brought into surgical and endoscopic practice over the last 2 decades of practice. It is not just sufficient to have facilities like this, but the passion to develop the specialty and the passion to develop integrate specialties is what is very important. Congratulations, Praveen, for achieving this. And because of this work, actually, at his young age is able to reach one of the highest positions of President of Association of India, which everybody aims for and cannot become. And truly, he is translating that very effectively For the first ever time, I have seen that the president of ASI getting involved into active academic works, taking it to the rural India. And so many times he keep putting pressure on different faculties to make sure that the academic activities go on and then spread this knowledge to the nook and corner of India. Congratulations for the phenomenal work, and I hope whatever you have in your mind get translated in the next few months of your tenure and also as a subsequently in your tenure. Thank you so much. I've been asked, actually somebody, I think the person who was introducing was saying it is conference for endoscopy for surgeons. I think it's endoscopy for surgeons and endoscopy by surgeons. That's the true thing of that Bestos translated this entire meeting. When he started this, when he conceptualized this, actually there was a lot of resistance actually from the gastroenterologists. But obviously this is understood. Actually the gastroenterologists feel threatened by the surgeons doing endoscopic procedures because looks like the surgeons can do procedures, if not better, equally good as some of the very senior gastroenterologists are able to do it here. So it is just the practice, and it's how much of volume that are involved with that gets you onto the practice. And the practices that are available in India are variable. In some parts of the world, actually, I've traveled extensively. Even in some of the very well-developed countries like US, if you go to the remote places, it is the surgeons who practice endoscopy, not the gastroenterologists. Even in India, many of the, for many inaccessible areas, I think it is the surgeons who do this endoscopy work rather than the gastroenterologists. So I feel actually this fight between the surgeons and physicians will go on, but ultimately we have to keep the patient at the center of the attention and see what best can be done. In metros, actually, it may not be possible for you to in metros, it may be very difficult for surgeons to practice endoscopy work. But what I keep telling people is you don't have to practice outside your theaters. The amount of work that can be done in the theaters is far more than what can be done in the outpatient to diagnose this. So if you get endoscopy incorporated into theaters, the amount of work that can be done itself is very huge, and it is going to change the outcomes of patients. Okay. So actually, I thought I would talk on endoscopy in general, but actually Praveen asked me to talk on the newer emerging specialty like artificial intelligence. This again, I keep telling people actually, see there is again a debate whether AI should be practiced or not actually, but the way it comes actually, I think everybody, be it clinicians, surgeons, people who take up AI are the people who are going to survive. It is not that AI is going to replace, but certainly it will replace doctors who are not practicing artificial intelligence. That is for sure. A strong disclaimer from my side. Why am I talking about artificial intelligence? I am not as intelligent as Albert Einstein, so I take help of John McCarthy, who started this artificial intelligence. And I am not a coding person. Surgeon, I'm a scalpels is my specialty, not syntax. So I might be, some of you might be very IT experts here. So if I misspell some of these things, kindly excuse me, basically because I practice what is translated into clinical practice. I'm not involved into coding. And why am I talking about this? Basically because I come from Hyderabad, where Hyderabad lingo is the first language. Anybody who comes to Hyderabad will know what Hyderabad lingo is. And coding is the second language in Hyderabad. And we have started a center of artificial intelligence in people like me who can top up my intelligence. So we have started this intelligence so that we can use this for clinical purpose. And I've been a science fiction buff right from the beginning. And even before the term artificial intelligence was coined, many of the science fiction movies and the print showed artificial intelligence, how it was practiced. And I take pride to say that actually most of these things what were predicted almost 5 to 6 decades back are translating into clinical practice as in today. I'll give you this classical example. I keep showing this movie actually. I think some of you would have seen alien gets into the body somehow, but the best part of the movie is how this alien that gets into the body is removed from the body as an outpatient procedure without making an incision in an automobile. Phenomenal concept of this movie, and this is the basis of our natural orifice transluminal endoscopic surgery that was performed way back in 2003. This is, for some of the juniors here, this is endoscopic appendectomy, not laparoscopic robotic appendectomy. You're going through the stomach, making a hole, getting into the peritoneal cavity. And then you understand actually what the biopsy forceps that Praveen just used has got a hot biopsy forceps, then you dissect the mesoappendix like this. You understand actually, and then at the end of the thing, you don't have catgut sutures or suturing stuff those days. This was in 2003 through 2004. So we could just ligate the base of the appendix with the endo loop, which is still in clinical practice now. That is the endo loop that is applied onto the base of the appendix. And then use a snare, polypectomy snare, to cut some problem with the thing here. And then irrigate the right iliac fossa. And once it is done, actually, that appendix is picked up with a rat tooth forceps and get it out to the mouth. This, actually, when I showed this initially, that Time magazine covered this in 2003, 2004 as the biggest revolution. There were a lot of brickbats when I showed this, actually. I'll tell you a story when I went to present this in the American College of Surgeons. When Philip Morey went to present the first ever laparoscopic cholecystectomy in US, he was mooted out of the auditorium. Believe it or not, this happened. When he went, he was mooted out of the auditorium, and Philip Morey said that he'll never go back to US for any academic meetings. This is a true story. So when I was invited to almost about 15, 20 years after that to give this talk on this, they invited Philip Morey again. With lot of persuasion, he is asked to come, and then he agreed to come. And the president of the thing, actually I can show you the repeated emails, he said, "Are you sure that you want to show this in the American College of Surgeons?" I was no voice like Praveen those days. See, least bit bothered about who is sitting in the hall. See, we just want to go to the auditorium, just go do a presentation and come back. So I thought it could be a small gathering like this, which could, on the day we went, actually, it was scheduled in Hall E of the thing, actually. So by the time that came, actually, it looks like there was a lot of changes, a lot of interest that was shown, either to boo us out of the thing or whatever it is. So they changed it to the main hall. The main hall in one of these, you understand, this has got a capacity of 15,000, 20,000 people. So I never knew this, but they changed to Hall A those days. And I never knew what Hall A was those days, actually. So I went to the Hall A. Philip Morey was already there in the thing, actually. He said, "Be prepared for the same thing, Dr. Rao." I said, actually, I was not aware of this international politics and all. You understand what I'm saying? Actually, basically no voice into practice. You just go there. We said, okay, you just go present it, whatever it is. I think if I had known that actually preemptively that something like that is going to happen, maybe I would have jittered. But surprisingly, I never bothered about this, and he had a massive crowd, about 15,000 people sitting in the hall those days actually. And this is the first ever time actually I mean, you understand, talking to 15,000 people is not a joke actually. You have some jitters in the beginning, and then, but at the end of the day, surprisingly, we had a standing ovation for that presentation those days. So the entire concept of surgery has been changing actually, so people started accepting that actually. So can something be done for this actually? And the other thing that I'm talking about why science fiction is basically because all of us have gone through this COVID pandemic. Surprisingly, if you see these movies, all these movies were released a decade back before COVID. Every single movie showed how COVID can start, from where it can start, how it can devastate the population, how the vaccination can be produced, and how postmortems can be done in this. A decade back COVID happened, all these were predicted, and we've gone through all this without any. So science fiction people who are able to preemptively do the things actually are phenomenal masters who are able to predict a lot of things in future. And why am I talking about gastroenterology? AI is affecting all the specialties, but I will take the example of gastrosciences basically because we are involved with gastroenterology. And gastrosciences is the most happening specialty as in today, whether you like it or not. It is not cardiology, it is not pulmonology, it is not neurology. In the next 5 years or so, actually gastroenterology will make inroads into diabetology, metabolic surgery, and the gut microbiome procedures that are going to come, going to change the way in which we practice the entire medicine. So gastroenterology is the most happening specialty, and for all the juniors sitting here, I think we should pursue either a medical gastroenterology or a surgical gastroenterology. It's very curious, heavily invested specialty, and most rapidly expanding emerging specialty in clinical practice. Now, what are the challenges that we have in diagnosis as in today? We have challenges in diagnosis, choosing appropriate therapy, determining individual responsiveness, and predicting the future course of the disease. All said and done, though we practice, these are all the challenges that we have. And this is basically because, as in today, the entire thing is based on natural intelligence-based equations. All of you know about what equations are right now. Whatever we practice today are all equation-based. Now, this equation-based management that we practice today is yielding acceptable estimation in only 50% of the people, and the rest it is either overestimated or underestimated. This is basically because we are dealing with a heterogeneous patient population, and there's a huge data that is coming from imaging labs and basic research. Analysis of all this is very, very time consuming and conflicting, and there is variable reporting even between clinicians and observations, and variable management and follow-up protocols. So I'll make a provocative statement saying gastrosciences as in today seems to defy natural intelligence equation-based management, and can artificial intelligence overcome the challenges that we have in current day clinical practice? Now, gastrosciences has everything that artificial intelligence reads. Large data sets from the EMR. Praveen has got one of the best things, he's getting everything translated to EMR. Kudos to that actually. Imaging modalities like endoscopy and radiology. People are vying to purchase videos from you. Please, if ever at all any software company asks for a video, don't just give it. Each video could be worth few thousands to few lakhs. Don't share your data with anybody else, please. And we have huge data coming up from Ultiomics, which is going to be very, very important. The end result is this entire data, we have these algorithms written with a changing the way in which we diagnose, in which we're going to treat, in which we're going to prevent, follow up this patient. That entire circle is going to change in how it is going to practice. And artificial intelligence has everything gastrosciences needs as in today. Surprisingly, if you see any of the AI journals, India stands number 3 in the number of publications in AI. Basically because of the huge amount of IT network that we have, and India stands number 3 as in today in the number of AI publications that are coming globally. And consciously, subconsciously, whether you like it or not, you're all following artificial intelligence. ChatGPT started writing essays, articles, and started making presentations. GPT-4 takes high school examinations better than students. We have software which can convert text to realistic pictures. And we have Sora which can convert text to videos. Tomorrow, I don't have to be an expert like Praveen Furaminchi to show the cholangiocarcinoma that you showed just now. I can just text it and I can get a beautiful video equivalent to what he has done today. So, whether it's positive or negative is going to be a totally different issue, but 90% of you are sitting here consciously, subconsciously following AI, and I'm sure this is going to increase in future. Pancreatic diseases, actually, I'm talking about all this basically because some of the work is being done in our center. It's able to differentiate between various cystic neoplasms, able to pick up pancreatic cancer even before the radiologist can pick it up on a CT scan with very high accuracy. It is able to differentiate between different neoplasms in the liver, differentiate NASH from fibrosis, differentiate various types of tumors in the liver with very high accuracy and sensitivity, specificity. And the basic thing I'll show you, we have a project that is going on in AIG that replaces the fibroscan today. Just on the parameters, it will tell you the amount of steatosis and fibrosis. So fibroscan, which is an expensive stuff, can be taken out from your practice if you use this algorithm. Now, some of you younger students like this, actually you must be following this movie Predator 2 that has come. They use this infrared light to pick up camouflage structures. Whatever Praveen has shown you yesterday about this narrowband imaging. Now this narrowband imaging is the natural intelligence initially we started picking up. Now we added AI to this actually. So even for a no voice endoscopist when he is doing, it will alert the areas of pathology. It will alert so that you have to go back to that area and target the biopsy. As in today, it is not replacing, but it is helping us not to miss lesions and helping us target biopsies, so the number of negative biopsies are avoided. That's the beauty of artificial intelligence. Now after this, we have this movie called Predator 2. Now this uses infrared light, and this is what got translated. Believe it or not, this is what, and the, translated to the ICG that we practice. Now RDI is another modality that has come, which is making vessels very prominent in the endoscopic practice, and this is helping procedures like POEM to be done safely. Now this is again an algorithm written in our own department actually. POEM procedure being done, and on the left you can see all the parameters. It will tell you whether in the right space or not. And whenever we have this vessel that are getting prominent, it will alert you. The vessels get enhanced, and it will tell you that this vessel requires prophylactic coagulation. So you see this on the, there's an alert on the left side that is showing that it requires prophylactic coagulation. Unless and until you coagulate this, it will not allow you to proceed, and if you proceed, it's a disaster. So by reading so many things, AI has picked up that this vessel is going to bleed, and you cannot overlook this procedure. And as you go down the thing, it is going to identify the sling fibers, everything is going to identify, so that you can just have this on the parameter on the left side. Now this is being validated. Actually the next procedure in AIG will be purely done on this in the live conference, wherein you have this AI going on one side and the POEM procedure going on the other side. This is validated over almost 800 to 900 POEM procedures now, and the accuracy is phenomenal. So the younger surgeons who are getting into this practice, so they can use this to make procedures safe. Colon polyps, again, it's a thing not very common, but increasing detection in our part of the world. And we have shown that lot of AI work that done at AIG hospital to show that how it can be picked up. And this is the model that was developed at AIG to enhance the polyps. On the left is the white light, on the right is the AI integrated thing, which enhances the polyp. Then it is going to further magnify and tell us what is the nature of this pathology. So all those polyps which are hidden behind the folds can be picked up right now by using this AI technology. It alerts us that saying that you're missing a polyp here, please go back and then check the thing again. That's the beauty of these procedures. The next extent is this, of course, actually some of you would have seen. So we have an endoscope. We have actually the microscope that is fitted onto the thing. And now you have AI incorporated into the thing. So as you touch this lesion, it will tell us whether it's a neoplastic lesion or a non-neoplastic lesion. So this is what happens. So the number of negative biopsies are avoided as in today. So the number of positive biopsies become more and more. So we have this AI that is integrated into the endoscopy practice. Believe it or not, actually simple tests like ultrasound is able to pick up biliary atresia with almost specificity of 86%. You don't have to do any nuclear scans, anything of that sort. Simple ultrasound images, you train the thing, it is going to pick up almost in the tune of 90%. Endoscopy practice again, as in today, to detect or to predict CBD stones, we follow ASGE and ESGE guidelines. AI has shown that it is better than ASGE and ESGE guidelines in picking up stones from the data that you feed. And it is able to identify papilla. It is able to predict cannulation difficulty in almost 70% of the thing. Even before you go in, just by looking at the papilla, it will tell you whether it's a difficult cannulation or a simple cannulation. And we have a scoring system of difficult CBD stones, which are going to be difficult to remove, which are going to be easy to remove based on several factors that are fed into the thing. And it will tell you whether it will take single session or multiple sessions to clear the stones. And it is also able to predict post-ERCP pancreatitis even before we start the procedure. This is a sepsis prediction model that is developed in our own hospital. The entire hospital is linked to this. All the inpatient ICU patients are dynamically recorded onto this. Based on several parameters that are picked up into the thing, patients are at risk are categorized, segmented, and it comes onto the war room screening, and it comes onto the mobile. We have an AIG1 app that is there, actually it alerts all the people. The number of code blues in the hospital have dramatically reduced from almost 25 to less than 5 after we introduced this sepsis model into the hospital. Because it's alerting, and it's not only alerting the sisters, the staff, the consultants, so we are able to see these patients before they land up in any emergencies. Likewise, it is helping us in reduce the amount of radiation that we are exposed today. We are very happy, actually, cardiologists, gastroenterologists, happy doing procedures, but we don't know the repercussions of this 10, 15 years from now. I think we should also be very careful and use these AI integrated softwares. Cholangiocarcinomas, again, it is huge, making huge dent into practice in differential diagnosis, assessment, prognostication, early prediction of recurrence in these patients. And the cholangioscope that you've seen right now has this AI component now. It is just a software that is integrated, and I showed you the endoscope now. This will tell us whether it's inflammatory, interdependent biliary stricture, or a malignant stricture. If the area that is focused showing high red band, then it means actually it's an alert that this has to be biopsied. So in future it is, you understand what I'm not saying that it is going to, but it is helping us to change the way in which we practice. And you see the thing actually, The brush biopsy is 63% accuracy, biopsy is 61% in cholangiocarcinoma, and AI is almost 90%. So basically it is combining all this data that you feed into the thing. Capsule endoscopy, again, a lot of you know about it, actually evaluated for small bowel. The biggest limitation was to maneuver this capsule in the body. Now, this actually, Paul Swain is a good friend of mine actually. So when he tested this, actually, this is how he tried to maneuver the capsule within the body. He used a magnet to maneuver this capsule. He swallowed it himself, and then he used a magnet to maneuver this capsule in the body. Now, I asked Paul Swain where he got this idea from, because Paul Swain is one of the person who was with me during the development of the Notes accessories actually. Now, he showed me this video actually, his counterpart Bond movie, and he says he got this idea from this movie to use magnet to maneuver the capsule. You understand, all these are subtle things that happen actually. If you carefully follow this, lot of ideas can be picked up from a lot of things. And to an extent that now actually what we predicted almost 2 to 3 decades back is coming a reality. Capsule endoscopy is no more diagnostic. We can dynamically see the thing, the number of pictures it takes. We can load the thing with medicines right now. The way in which it is practicing going, I think it will replace all the conventional endoscopes today. All the thing that the person has to do is take a capsule from the dispensary, swallow it, and then it will give you all the data. I think we thought it is going to be take decade, but I think all this is going to happen very, very soon. Pathology, again, the biggest threat the gastroenterologists have are for the diagnostic pathologists and for the diagnostic radiologists. Whether you like it or not, diagnostic radiology will go. Please, all the radiologists here, actually, if you are not in par with what is happening, it is going to happen actually. Even diagnostic pathology, it's a big threat basically because, see, initially the gastroenterologists introduced an ultrasound and they have taken over radiology. You don't require a radiologist standing to interpret EUS images as in today. You understand what I'm saying? Initially they said you require a radiologist. But same thing happens now, the pathology images are being interpreted by the gastroenterologists now. So you understand what I'm saying? This is going to change, and we have our own publication showing how Crohn's stricture can be differentiated from a non-Crohn's stricture using artificial intelligence. GI surgery, again, phenomenal changes that are happening. The paradigm shift actually, as I showed you, ups and downs in the surgical specialty. There were periods of euphoria, then periods of people went into depression, the way we practice. But ultimately, as the technology is coming in, lot of changes are going to come. I'm sure that surgery is going to be at the next level with AI integration into the thing. I'll give you a couple of examples on the surgical side. You know, it is able to predict complications in patients undergoing major surgical procedures. Very high accuracy and specificity. And it is able to tell us which are the patients who are going to have recurrence following resections in surgical procedures. ICG is one modality actually used extensively here. Actually, all of you know about it for nodal clearance and also for tissue perfusion at the end of the anastomosis. Now, this is basically now we have AI integrated into the. You have an ICG integrated laparoscopic cholecystectomy. It will tell us whether you're in good planes. You understand what I'm saying? It is helping us to be in good planes so that you don't cause damage to the bile duct. Now again, as in today, we just go by the color of the thing and say, okay, this is adequately perfused or not. Now we have softwares which are doing objectively tell us whether the amount of perfusion is adequate or not. Again, this is the software available in some of the companies, but developed in our own department to show the percentage of perfusion of the remnant pancreas following a laparoscopic Whipple's. So if it is about 80% plus something of that sort, then you are absolutely sure that the leakage rates are less. Or you can always revise the margins on this. So this is becoming part and parcel of every laparoscopic system right now. Again, you see this lesions like this. Initially it was difficult, but now we are able to differentiate between a well-differentiated, a moderately differentiated, and a poorly differentiated HCC based on the images that we see on the thing. And the accuracy of this is very, very high. So it all depends on what you're taking. It all depends. So the number of the decisions on table can change based on the type of pathology that you're seeing, from major resections to maybe non-anatomical resections in future. Yellow enhancement is other technology that has come in. Actually, it is enhancing the yellow color. You can see that white light and yellow enhancement. It is able to pick up subclinical strictures in patients with Crohn's disease. You understand, you talk about the fat creeping. Now this is able to better pick up fat creeping so that subclinical strictures can be picked up. Just to show you the difference between white light and yellow enhancement laparoscopy. There's phenomenal difference actually. You can stay in planes better, basically because of the sheer contrast. It is likely that the blood loss could be less, damage to the neurovascular bundles could be less using this technology. This is being validated with several centers across the world right now. I think the data is going to be published, but I think this is one of the technologies that is going to change in which we practice surgery. So this idea was borrowed, Olympus borrowed this idea from a movie called Avatar, I think, where you must have seen this yellow enhancement that was shown in the eyes. So I showed you the white light, blue light, yellow light. This is the ongoing project at AIG Hospital called Octopus. I think 6 months from now, Praveen asked me to come and show you. I'll show you the data of this. This system is going to automatically change colors based on where you're operating. And it is going to help identify those structures, make those vessels prominent so that you're in better planes, avoid damage to the major neurovascular bundles, especially. We are doing this for the anterior section procedures, and I'm hopeful that this can translate very soon into clinical practice. So I have some initial data, but basically because of patent, I'm not showing this, but the project is called Octopus. It's going to change colors automatically. We don't have to go onto the processor and press the button in the processor. And then we use this endobrain in laparoscopy actually. Again, I'm not saying this has to be used, but innovative people like Praveen know you want to use everything and see what happens. So we use the same endobrain in diagnostic laparoscopy in a patient with unexplained ascites. And you can see this, the same thing what it picked up on colonoscopy, we are able to pick up and helping us in targeting biopsies. So the number of negative biopsies can be avoided. You understand what I'm saying? So you can, availability of technology, you have to use it to the maximum to see how it can be used in clinical practice. The latest thing that has come is called as the vivoscope or the confocal microscopy, that is AI integrated pathology right now. You take this nodule, no stains are required, you just put it on the machine. The images that is going to give you in less than 5 minutes is similar to H&E stain. These are the images that we get. So that's the reason why I'm saying you should also learn pathology simultaneously. Less than 5 minutes, you get this. Technology is expensive right now, but I think as more and more people come into practice, I think this is going to be cheaper, like what happened for laparoscopy or robotic surgery. Again, this is another project that I would like to share. Again, I'll show it to you from 6 months from now. We have intelligent staplers right now. Now we're integrating these staplers with the vivoscope. So the next time I put this staple, I'll know whether the staple line is positive or negative. So the number of positive staple lines that we see in the histopathology 10 days after we do the procedures can be changed on table now. So the moment you put a stapler on, that will tell you whether that's a positive margin or a negative margin. So all this is possible actually basically once you start integrating these technologies here. And again, there's a lot of data to show that AI simply can change. Again, this is again a thing that is done in our own hospital. Now, I'm not saying in spite of all said and done, we still cause bile duct injuries. So we have so many technologies to avoid this. So this is one of these things. Now we started segmenting right now. Right now it is able to identify, you understand, that is. So in the days to come, it is going to identify the cystic artery, cystic duct. So parallelly, we'll have a monitor which shows that which are the structures, which are the. I'm not saying continuously it has to be done, but whenever we have difficulty, we can always change to this mode to see in difficult cases. Now it is being validated for simple cases. So as more and more case gets validated, I'm sure it is going to tell us what the structures are. IBD is going to make a big dent into clinical practice. Now we started a project, actually some of these patients with ulcerative colitis end up with a permanent ileostomy. Now, we have a device for this right now. It's called the TICE ostomy secure that is put onto the ileostomy. So the patient can open at his or her comfort. It's like a cap on the bottle. So they just can go to the toilet and open the thing and then empty the thing and then come back. This is no artificial intelligence, okay? This is natural intelligence. But what is artificial intelligence in this is we got sensors fixed into this right now. So inside of the thing, DICE device, we have sensors. So it will tell us the pressure. It will alert the patient on the mobile what is the pressure they have to go to the toilet to empty. We are dynamically monitoring the fecal calprotectin. That's what the gastroenterologists want. And it is like the smart toilet that you have. Because the stool is in direct contrast with the device here, every single thing that it all depends on how much money that you want to invest. Every single parameter, including the microbiome or the sequencing, can be done if you attach sensors to this. So it can, once you have the thing, actually how much you integrate the technology is what is going to be important. This, I think some of you would have seen, navigation surgery, integrating the thing. Actually, I'm just waiting for Praveen to get this system into this hospital. I think the next workshop, I think you should have this, Praveen. So basically, we have all this data that is integrated right now. It's like a roadmap in the theater right now. You understand? You have an image focused onto your liver, point A to point B. It will tell you, guide you whether you have the right direction, wrong direction. It alert even before you touch the vessel, it will tell you that you're heading towards a vessel. So change the direction. So number of R0 resections are going to increase. Blood loss is going to be less. So these are all actually actively practiced in neurosurgery, but delayed on GI surgery basically because of the mobile structures. But this is again becoming a reality right now. Now, robotic surgery, again, misconception. Basically, I think that's what we spread the message. Robot doesn't perform. It aids as surgeons today. But if you see any of these movements, please follow this. Actually, I don't know whether you know this. Somebody shows you the lesion. You recognize it. You decide what to do, and you move your instrument. These are the 4 steps that surgeons follow, consciously, subconsciously. Now, AI gets into each of these phases of the movement that you do. So, end result is it is able to show, it is able to recognize, it is able to decide, and it is able to move. Please, I'm not exaggerating it. And the accuracy with which it is doing right now is 90% plus. The end result of this is the first ever experimental work that was done to show a small bowel resection in a porcine model can be done, simulated on a system first, and once you are sure that you have done your procedure well, you let the system do the procedure. So you want to do a lap chole tomorrow, you can do the thing on a system first. Once you're sure that you have identified the text properly, you let the system do the procedure. This is not very far from clinical practice right now with so many technologies coming in. So these are going to parallelly run the thing. And NASA has started this program actually for all the youngsters here actually. This is a beautiful movie that shows surgery in space actually. For some of the videos not doing, that's okay. But I think they started this program of surgery in space, and then they started people to, so we have sent our first application. I think hopefully one of my junior consultant gets a call so he can get trained for surgery in space. So because this is the next specialty that people are looking at for a decade from now, with so much of space travel that is happening and remote control surgery that you talk about. Nutrition is other thing actually. All of us have beautiful ICUs actually. These are all the nutrition is equation based management, and we have alerts for every single thing in the ICU but for nutrition. The surprising fact is actually the morbidity that we are seeing as in today is basically because we are depleting these patients in the ICU. It's called iatrogenic malnutrition. Basically because we are basing the nutrition based on equations. Now we have a technology called indirect calorimetry which is able to check the thing, though it's slightly expensive. We did a pilot study in our own department. Now we're getting this equipment now. Major surgical procedures, it is shown that we are depleting the patient by 30%. 30% malnutrition is what is responsible for the morbidity that we see. Suppose we overcome this, I think our outcomes could be better. than what we are seeing in clinical practice today. This is called indirect calorimetry. Very simple technology, but slightly expensive, but I think 2 or 3 companies come out again, is going to come into practice. We have had, on the administrative side also, we have some beautiful publications that we had. We had this PRISM technology actually that's converting text to, sorry about it actually, okay fine. It's okay. It is converting speech to text, in the sense like we want data to be entered. Doctors don't want to enter in that because they feel they're losing the eye contact. Now this is converting, as you're talking, you don't have to enter anything, it automatically converts the language to text. The best part of this is it's converting various languages. The best part is, even if you flirt with the patient, that part is excluded. You understand? That's the beauty of this software. I mean, and the best thing that I noticed as we started using this, validating the procedure, was a lot of these international patients who used to come with an interpreter now. Now, as the patient is talking to you, it is dynamically showing the text in the English language. So you don't require interpreters in future to do this actually. This is again being validated in our own center. Some of you can come and see. And again, the hand movements of the surgeons and the endoscopists, again, we are tracking this to make sure that they don't have any trauma in future. Now, the biggest question that is asked is, will clinicians and surgeons become irrelevant in clinical practice? And basically because the way in which ChatGPT or AI is taking care. I strongly believe that for counseling this has to be used. We started using this actually basically because the tone in which it talks is very, very good. See, you have a death in the hospital, you have about 100 attendants standing in front of you. First attendant you can talk to, second, okay, third, 10th, he gets wild and you get wild. But surprisingly, it is like a Google map. 100 times you take a devious course on your car, it doesn't change the tone in which it will tell you that you're taking the wrong path. The same thing happens in AI. Is the tone that is responsible for all the morbidity and the casualties or the whatever thing that you have. I think this can be overcome by this. And we have
never replace them. My goal is to enhance patient experience with human oversight, and in the future, with appropriate training, my role may increase for evidence-based circumstantial requirements. I look forward to learning from the clinicians' experiences to continuously enhance my skills in the field of gastroenterology and other specialties.
This is what we developed 6 months back. Phenomenal, actually. The other day, Dr. Vineet Ahuja came to our, the AIMS professor came here. He, after a session on pancreas divisum, we went on to show him this actually. And I was quite, this thing whether it will pick up the recent literature that you had actually. So Vineet was asking this, can you give me 2 recent publications about the use of endoscopic treatment for pancreas divisum? Surprisingly, it picked it up. It all depends on what you feed, you understand. Now we have put this in the outpatient rooms actually. So a lot of those simple questions that the patients have can be answered by this. See, and the amount of time that you have to spend with these patients can dramatically come down using this software right now. Lot of data to show that acceptance levels are very high right now. And if you follow this actually, just 4 days back, Microsoft announced MAI DXO, which they feel is better than doctors. I don't know, this is an MIT publication just published 4 days back, and the accuracy of this was 80% AI was able to do, 20 doctors pass this in 20% of the cases. I don't know which section of doctors they have taken, but anyway, this is the publication that has come. I mean, you understand it's a threat to the doctor community, the way it is going. So it cannot substitute human clinical reasoning, but as in today, we have to make sure that we feed it properly to use it properly. It has to be like evidence-based medicine as in today. It has to go through the bench to bedside. You cannot just write an algorithm and use it on the patient. It requires clearance from the DCGA or the FDA. It has to go through all the clinical trials and get approvals. The evidence is something like the evidence-based pyramid in natural intelligence. And there are several concerns in this. Will hospitals purchase, and legally who would take the responsibility? I'm surprised actually. Yesterday I met one of the the justice in Supreme Court, and he tells me that AI is integrated into the High Courts and the Supreme Courts also. So as we are practicing this, they are also practicing this, and he tells us that by the time the client comes to them, he is well versed with all the rules that we have and all the laws that we have. So it's same thing like what we have. Suppose if you are not abreast with what is happening, actually you will be left behind with this. And who will validate this, and who will be responsible for all this? What if the system crashes, or if the systems are getting delayed? And what if system is hacked or corrupted? I'm showing the science fiction movies because all these have shown how it can be done. Recently, 2 major hospitals in Delhi, the system was hacked and the entire system went haywire for 1 week. It could have been a natural thing, but it could have been hacked by somebody. You understand what I'm saying? To take the information from a prestigious institute. So what if the systems are hacked by these things? And as humans started heavily relying on machines, surprisingly machines started learning from machines. It is not an exaggeration. And as we embark on this AI journey, we are not just creating characters, avatars, humanoids that simulate emotions, but you're also fostering an undeniable intellectual connection and involvement with these elements. I'll show you a couple of examples of this actually. Now, science fiction movie shows what if AI becomes self-aware and starts self-inventing itself. These are all the things that are shown that happening as in today. And what if human consciousness merges with the machines? And what if we create bioengineered humans, replicants which are indistinguishable from humans? All these are not theoretical things, are shown in this thing, and some of this work is actively going on, and some of the work you would have already seen in the print as in today. And what if the program machine start believing themselves as humans? It is possible. And what if I fall in love with this mirror that I created? My decisions could be totally disrupted. You understand what I'm saying? These are all the things that can happen in future as AI gets into clinical practice. And who controls who? Initially we thought humans are going to control artificial intelligence. Actually, I know people who follow this. Recently one of the very senior Google executives resigned about 3 months back because he feels that AI is going to control AI, and he feels that is going to be disaster. So he threatened, he resigned on those grounds, saying that future is going to be totally different, so he doesn't want to be part and parcel of that system. And it also is warning about the evil aspects of artificial intelligence. Some of these movies will tell us the evil aspects of artificial intelligence. So as in today, it is limited to research setting. We are using it, validating it, but it has a very bright future. I thought I'd had to turn 20 years younger to see all this happen. This is my AI generated image. But this Sundar Pichai, actually, people who follow this, actually, he's invented this quantum willow, you understand? And it tells us what can take 5 decades can happen within the next 5 years now. Because the processing speed of these things is, so I don't have to be like this to see all these changes. I'm sure I'll be able to see all this in the next 4 or 5 years. And I keep hoping that something like this happens in reality in future. Patient with a disease put on a table, diagnosis, treatment done, and the patient walks off the table. This is not an unrealistic future thing that you're not talking about. Lot of things that you're talking about. Today, if you talk about patient with early GI malignancy, Praveen, it comes to Praveen, he'll do an endoscopy. On table, he'll tell the pathology. On table, he'll do an ESD. Are we not doing the same thing? Initially, it used to take a month, but now we are putting the scope, diagnosing it, and if we have the facility to do the ESD at the same time, finished. The patient comes in, walks out, cured of malignancy. So the same thing is going to happen for advanced diseases as we do in future. So as we keep talking about, we think that actually there are people like me who strongly believe in artificial intelligence is not a thing, and we have to have our own intelligence to this. And this science fiction movie shows that you can have an extra hard disk fitted to your brain to increase your RAM processing speed. People again thought it's an absurd idea, but you understand, you're talking about these brain implants right now. This has become a reality, and Elon Musk made this a reality right now. We have got the first patient with a chip onto the brain right now, and a paraplegic patient is able to move basically because of this chip. So phenomenal transition that we have in clinical practice. So both AI and AI into natural intelligence is going to change the way in which we practice medicine. So as we're talking about this, actually, like the system can get corrupted, your brain can also get corrupted. Even now, actually, our brain gets corrupted by so many people around us, actually. Especially if you have nonsensical people around us, it gets corrupted. But we have a system inside it, it can get corrupted. And it's called brain jack now. This is not my terminology, please. It's scientifically published terminology called brain jack. And looks like you have to unbrainwash yourself repeatedly to overcome this corruption that is going on to your brain in future. So to conclude, Praveen, actually GI disease management is very complex and expensive as in today, as we see more and more disease patterns. Improving clinical efficiency and optimizing healthcare resource management is of absolute paramount importance. Evolving advances in AI are promising with potential to revolutionize diagnosis, clinical care, detection of lesions, tailoring treatment, improving current survival, and predicting the treatment response. AI is helping in assisting newer associations and between variables, and potentially leading to changes in which we practice GI medicine. So in future it is going to be a precision medicine centers. It is no more going to be about this. Actually, surprisingly, we seen that actually now we all follow standard textbooks. Actually, our cardiology department in AIG has done a wonderful, you put the patient on these antiplatelets, whether you don't know the dosing is correct or not. The pharmacogenomics is telling us the optimal dosage of this patient. It is not dictated by the textbooks now. Each and every patient is totally different. The medicine, whether it's going to help them, not help them, how much dosing to be decided is going to be decided for pharmacogenomics. So the side effects of medicine can also be decreased. So as the specialties go into the thing, actually, the next month, actually, we are starting a microbiome clinic in AIG hospital. For the first ever time, we have a microbiome clinic wherein, because we feel that the gut microbiome is the reflection of the face of the person. It is not the heart which is the reflection, please. It is how your gut works, and the gut bacteria seem to determine everything. If you follow this thing actually beyond your convention, it is telling us that why people are going into schizophrenics, why we are getting Alzheimer's, why we are getting many other diseases. You understand? It's basically based on the gut microbiome. And if you're able to alter the gut microbiome, either by changing the diet or by inculcating some of the practices, most of the diseases looks like they can be treated as in today. So precision medicine is very, very important. Microbiome is the next big specialty that is coming in. I think you have to keep watching these specialties, and gut microbiome related therapy that is coming in the form of fecal transplantation is a big thing in clinical practice actually. For all those who don't know, there is a huge stool bank in Hong Kong. I think it's bigger than any other tower that you have in Hong Kong right now. Is not an exaggeration, please. They've screened healthy individuals, and every morning, suppose they go do their morning job in the bank, they get paid $50. And the same stool sample after given for the patient is sold almost for $250 right now. So the initial stool sample, now they're called capsules right now. So now we're getting it in a capsule form. Initially, when we many of you followed, we used to do this fecal transplantation, take an endoscope, inject this into the colon for ulcerative colitis patients. Now we don't do that. Actually, we just have to follow these capsules. It just look like normal capsules, which are going to totally revolutionize. So gastroenterology, please, is the most happening specialty. Don't forget, forget about cardiology, forget about neurology, forget about pulmonology. I think stick to gastroenterology. I think all of you are going to prosper. Thank you so much once again for the patient here in India. And I'm just hoping that Praveen, with all his resources, connections, positions, should do this in MGM. Looking forward to this.
With immense gratitude and admiration, I really take this moment to thank our esteemed orator for such a wonderful session. You have really opened our eyes about usage of AI in our field in future. So through your insights, we now see that AI is not just technology, but how it can be used to transform the patient care in future. Thank you so much, sir, for such a remarkable oration. I now request Dr. Praveen Suryavanshi, sir, to felicitate our chief guest, Dr. G.V. Rao, sir, with memento.
All the procedures actually now are 3D printed actually. The liver tumors are all 3D printed. Actually, we get models like this actually right now. It's very good for training right now. So even before we do a major liver resection, we have a 3D printing like this of the thing so that it can be used for teaching. This is available right now actually. Thank you so much.
Thank you so much, sir. We'll proceed further with the remaining cases for today. Thank you all. We'll start the remaining cases within 5 minutes.
Hello, hello.
अभी मेरे पास नहीं हेलो डॉक्टर मकरन हॉल कनेक्ट मी टू हॉल हॉलला कनेक्ट करा ना हॉलला कनेक्ट करा हॉलला कनेक्ट करा हॉल डॉक्टर मख्तर डॉक्टर सुशील अरे
Hello.
We are starting the cases.
Yes, yes.
Okay, so we'll be showing first is metallic stent.
Yes, yes.
To OT number 3, procedure by Dr. Mandar sir. 77 years old male came with complaints of pain in abdomen since 15 days, loss of appetite since 15 days, itching over the body since 15 days, icterus is present. His labs are within normal limits. Total bilirubin is 10.9, direct bilirubin is 8.7. MRCP suggestive of irregular mass lesion measuring 9 by 8 by 20 mm. Features suggestive of hilar cholangiocarcinoma. Plan is ERC with metallic stenting. Over to you, sir.
So, by Rao sir, now we are back with the live cases. So, this is a similar case with a hilar cholangiocarcinoma. Ekhadan dokar support kar. So, to save the time, I have gone inside. I have put my scope into the stomach. I am trying to go across the pylorus. So this is the pylorus. So this position looks a little better than the previous case, but let's see. So the ampulla is here, the papillary orifice is in those holes there. So like always, we'll first try with the wire guided cannulation using a sphincterotomy. The MRCP report showed a Klatskin tumor with complete separation of both the ducts. So probably the right and left duct are not communicating. So in ideal situation, we should be stenting both the ducts separately. Let's see. Bend, bow. Wait. Wire. Tip of the wire. Yeah, thoda, yeah. So sometimes if the here so you can use the tip of the wire to gain access inside the by common channel. पकड़ा स्कोप बो पकड़ा स्कोप हलून देऊ नको रे
Mandar?
Yes, sir.
There are some senior urologists here. They are asking whether the picture of endoscopic camera can be focused.
म्हणजे
आपण जे लॅप्रोस्कोपी मध्ये फोकसिंग करतो ना मी म्हटलं एंडोस्कोपला तशी अरेंजमेंट नसते
पकड़ा नहीं नहीं काय बो थोड़ा सा वायर टाका सर थोड़े
हेलो
कमी पकड़ा स्कोप तू नहीं पकड़ा रे
हेलो Am I audible there, Makaran sir?
Yes.
So now you can see Mandar is a bit struggling with the position of the scope because and what he is trying to do is using the tip of the terimo to get access and stabilizing the ultratome.
Yes. Is there any role of pre-cut?
Yes, sir. I'll try with this. If I fail to cannulate, then I'll go for pre-cut. कमी घ्या वायर मागे द्या परत टिप बघा वायर So I am not able to pass into the common channel.
Yes.
बघा सिस्टर बघा वायर थांबा मागे नका घेऊ पूर्ण वायर पकडा स्कोप रे घट्ट पकड रे भाऊ हलून देऊ नको
It appears to be a very floppy ampulla which gets folded on itself.
बघा परत वायर मागे नका घेऊ I think here also I'll have to go for pre-cut. थोड़ा बो करा, थोड़ा बो, थोड़ा, हाँ, ट्राई विद द वायर. ठीक आहे, मागे नका घेऊ पूर्ण वायर. पकडा स्कोप घट्ट. या आता बो करा. नको, कमी करा, कमी करा, कमी करा, बो कमी करा.
So you can appreciate that Mandar is very
वायर
gentle
थोड़ा
with the
बाहर,
ampulla.
वायर बाहर काढा थोडी.
Yes, yes.
वायर बाहर ओढा थोडी. If I am able to enter into the common channel, then the things become little easy. नहीं होता. बघा वायर. थांबा थांबा, मागे घ्या वायर थोडीशी. Yeah, pre-cut. Pre-cut. So I'll go with pre-cut. I'm not able to.
So Mandar has decided to
Pakada.
go with the pre-cut.
Yes, yes, yes.
So the more you try,
The pre-cut will be
the
difficult.
more edema it is.
Yes,
And things become more difficult.
yes.
छोड़ जरा. हाँ. वायर सिस्टर. हाँ हाँ, पकड़ा स्कोप. I'll insinuate the needle in the common channel.
Yes, yes.
And slowly I'll कॉटी बोंबली. तू काय एवढा हलतो रे? नुसता पकड ना. बोटा बदलतो, हे करतो. Back, back. So can you see, sir, the
Yes, yes,
mucosa
yes.
is prolapsing? Probably I have opened this now.
Yes, yes, yes.
I'll try with the Variceal cannulation. Yeah. So this sometimes this is called as excisotomy. So I haven't cut the muscle. I have just cleared the overlying mucosa.
Mucosa, yes.
तू ना मला हे दिसलं तर बघ कशाला म्युकोसा सारखं करतो. शांत उभा राहा ना. काही करू नको. वायर आली द्या ना. टिप टिप. या असंच राहू दे. टिप राहू दे. टिप द्या ना. कमी करा. बघा जात आहे का? नाही. थांबा. वायर बेंड बो बो जाते. मागे घ्या मागे. वायर वायर द्या ना.
Yes, yes, that can be the spot.
बघा. नाही. मागे घ्या मागे घ्या. थांबा काही नका करू. थोडं बेंड थोडं बेंड बो. थोडं थोडं कमी करा कमी करा कमी करा. बघा. मागे घ्या.
Fluoroscopic picture is not here.
हे अजून गेलो नाही. I haven't still cannulated.
Yes. There is one black spot
cut
in the inferior aspect. Is it the opening?
Sorry?
There is a black spot on the inferior aspect.
Yeah, but
below the cut.
I am going to cut further.
Yeah, okay.
Needle. द्या. कमी कमी कमी. थोडी अजून थोडी वाढ थोडी लांब द्या. या. बॅक. आणि बस 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 बस. थोडं निडल द्या अजून. छोटी एकदम. हां. बॅक बॅक निडल बॅक. वायर टाकले आहेत नाही ना. नको. वायर बघा. गेली. मागे 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 मागे. द्या थोडी वायर. टिप. हां. थोड़ा बो. हाँ थोड़ा. नको काढू नका. जाते. नाही नको नको नको. बघा. ट्राय. नाही. आपण लॅटरल करू. पेशंट लॅटरल करा. सोड. माउथ गॅग पकड. वायर. हां. बघा. नाही ते असं नाही हो. बेंड थोडं बो. हां बघा. असे करू. हां बघा. जाते. हां. ओय द्या मला. निडल द्या. अनबो करा. अनबेंड करा. निडल द्या अजून. Ask them to shift to that OT now. Start with adjoint OT. आता मार टाका. गाईडवर टाकून द्या.
आता हे तिकडे वेळ लागतो.
Yes sir, yes. Needle. Cutting needle. Needle. Yeah. थोड़ी लांब द्या. थोडीशी. हां नाही ठीक आहे. राहू दे. इनफ.
Dr. Makaran.
Back.
Yes.
And till the time Dr. Mandar passes a guide wire, we'll shift to another OT.
Yes.
Yeah. Please.
We'll be shifting to OT number 2. Procedure will be done by Dr. Joy, sir. 64 years male, came with complaints of difficulty in swallowing, liquids more than solids since 1 month, weight loss 3 kg since last 1 month. Patient is a known case of esophageal candidiasis, for which treatment has been taken. Hypothyroidism on medication since last 5 months, and HIV is negative. Patient is now posted for diagnostic orgidoscopy. Over to you, Joy, sir.
Ready?
Over to Joy, sir.
Yes.
Yes.
Yeah, we are starting with this upper GI scopy.
Yes.
Okay. गर्दन थोड़ा फ्लेक्स करो, नीचे की तरफ। You're doing it with a clinical suspicion of esophagitis.
Yes, yes.
Oh, the hiatus is very lax actually. Yeah, yeah. Oh, it's the hiatus is like it is open.
Yes, yes.
Yeah.
In J maneuver it will be very clear.
Yeah, yeah. I'll just go to the duodenum and then
Yes, yes.
come back. Duodenum looks apparently normal.
Yes.
The pylor is also fine. Will come here.
Yes, yes. This is grade 3 or grade 4.
Yes. So we have the Hill's classification for grading of the hiatus. So when the flap is completely closed, it is grade 1 or Hill's grade 1.
Just mucosa is seen.
Yes, and with respiration, if it responds to respiration, it is 2. This I would say it is grade 3.
You are able to see the mucosa of the esophagus. And with retroflexion, I think you will be able to enter.
Yes,
Yes,
we are
yes.
entering.
This is almost grade 4.
Yeah.
Grade 4. This is grade. With retroflexion, you are entering the pouch.
So large hiatus hernia.
Yes, yes.
Rest the fundus appears okay. Not much changes of, yeah, there is changes of esophagitis here.
Yes, yes. Can you put on NBI?
Yes, sir.
And see
NBI.
that lesion? Yes, yes.
Yes.
This is Barrett's, I think.
Yeah.
Sliding hernia also.
Yeah, it is a sliding variant only. Yes.
Yes.
So that is it. We come out. Okay, Dr. Mandar.
She has esophagitis.
Yeah, there is changes of esophagitis. That's what you mentioned. Yeah.
Yes, yes.
But it has responded well. I think she had undergone treatment. I think for candidiasis as well. So rest of the esophagus seems okay, considering the age.
Is this patient diabetic?
Is the patient diabetic? Hypothyroid, no diabetes.
Okay.
What was the reason you asked it first?
For candidiasis.
Ah, candidiasis. Yeah, yeah, that time it was mentioned. The viral profile was also negative.
Yes.
हिल्स ग्रेड 4 डाल दो. ठीक है. इसोफेजाइटिस LA ग्रेड 1. नॉन कॉन्फ्लुएंट चलेगा. LA ग्रेड्स 1 डाल दो और हिल्स ग्रेड 4 डाल दो. चेंजेस ऑफ इसोफेजाइटिस LA ग्रेड 1.
बहुतेक ओपन झाला आता. बहुतेक ओपन झाला. So I was not. Am I audible?
Yes, yes. Mandar.
So I was not able to cannulate. So I have extended the precut. And I have changed the patient position to lateral.
Yes.
So that gives us ampulla in a better position. There. And now Advai is here to help me. दे ना थोड़ा वायर. नाही जरा वर घेतो मी. झाली थोडं थांबा जरा. नको दे. हां वायर दे इथं. मला वर वाटतं. थांब मागे वायर. इथं कट करू थोडं. wait. Let's assess the ampulla again. कुठली ही ना गुलाबी. नाही थांब वायर टाकू टाकू नको. हेच वाटतं ना. वेट नाही थांबलो. या कुठे बघा ना. प्रिकटच आहे. नाही तिकडे नाही, इकडे सर. नाही नाही हे इकडनं. हां 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 या थोडं. थोडं वाटलं ना बाई, आता आला ना. इथे आता आलं ना तिथं. हां आता तुम्ही कापलं ना ते थोडं वाटलं आल्यावर का त्या थोडं वळवा. हां तिथे आता ते ओपन झालं ना. येस येस थोडंसं तिथं नाही वाटत ना, इथं थोडंसं इकडे तुम्ही करताना नाही एवढं नाही, या या तिथं जरा थोडं आत घालून बेंड करायला हवा जरा. बो कर रहा है, गेली का, गेली ना, गेली पीडी आहे ठीक आहे, असू दे हां, तिथे जाऊन बेंड कर पूर्ण. आता वायर बघा, जाईल बहुतेक आता, गेला तुम्ही पिढीच आहे हां, तर तिथेच ठेवून थोडं अजून बो करून बघा ना. हे वायर काढून घ्या ना आता, गाईड वायर हां, पिढीत नका ठेवा वायर. आता असं डायरेक्ट करून बघा, तिथं वरती गेलो ना आपण, थोडं इकडे नाही 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 नाही, थोडं इकडे होतं सर, ते व्हाईट ते दिसतं ना, हे हां हे इकडचं व्हाईट आहे ना, नाही नाही या तिथं थोडं इकडे, थोडं परत तिथे जायचं या, मस्त आहे, ग्रेट. शूट करा, वायर मागे घ्या, हां परत जा. Now this stricture was more tight compared to the previous stricture, so we spend more time in cannulation, but now going beyond the stricture is going to be a tough job. So let's see. थोडं बेंड करा, मागे घ्या वायर हां, आणि थोडं बेंड करा, बो करा, बो आणि आता परत प्रयत्न करा. टिप फिरवायचं, शूट खाली हो जरा.
Yes, I think no.
So we are working in tandem. So once the guide wire goes a little bit ahead, I am advancing my cannula.
Yes.
Sometimes I have to withdraw the cannula so that he gets some space for that wire to move. Now the main task is to go beyond the level of the stricture. The MRCP was showing a very tight stricture.
Yes.
And the confluence was completely gone. Who are you? मोठा होता गॅप मोठे होते. There was complete disconnection between right and left duct on MRCP.
Yes.
So that indicates the stricture is
very
tight and long.
Long, yes.
वर जाऊ मी जरा. वर जाऊ अजून.
कोणत्या केसला? ह्याच केसला फोडली का मागोदर झाली?
So for going across such complex stricture, you need a pterygoid wire which should be new.
Yes.
But they are really tough cases. So we'll try with another wire. Till then, if you want to shift to another OT, so you can proceed with that.
We'll shift to OT1.
Yes.
Procedure by Suryavanshi sir. 60 years old female with complaints of pain in abdomen post meals.
मागे येतो मी जरा, खाली येतो मी जरा. वर जाऊ.
We'll be shifting to OT2. Procedure by Dr. Joy sir. 30 years old male came with complaints of generalized weakness since 1 day. History of 1 episode of hematemesis. History of black color stool since 1 day. USG suggestive of altered coarse ecotexture of liver parenchyma. Gross splenomegaly with dilated splenic vein. Plan is for ogiroscopy, SOS, esophageal variceal banding with glue injection. Over to Joy sir.
दोन्ही ते जात नाही, राईटलाही जात नाही, लेफ्टला जात नाही.
It's a very young guy, not cirrhotic. So पेशेंट लाइट है क्या?
खाली होऊन
Okay. Yeah.
Yes, yes.
You can see 1, 2, 3, one big one.
Yes.
And
This is grade 4, I think.
yeah.
Grade 3, sorry.
एक मिनट पहले स्टमक देख लें. हाँ. These are some duodenopathy is also there.
Yes, yes.
Yeah. Okay. There are erosions noted here also. We'll just check the fundus. Yeah, this is in continuity with the esophagus on
yes.
the, yeah.
Yes, yes.
This one is here. This is the GOV1 in continuity with the on the lesser curvature.
Yes.
And this one is there. So what do we do? This will glue this one.
Yes, yes.
Yeah. Glue ले लो. इसको पकड़ लेना. ऐसे पकड़ लेना. एक मिनट सीधा हो जाने दो. एक मिनट रुक जाए. एक मिनट सक कर लेना. पॉइंट 5 cc काफी. ऐसे पकड़ लो. Needle out. Right. Patient light है. Needle out. No, needle in करो. Patient in. मेरे को वहाँ पे इंजेक्ट करना है. Bend. Yeah, hold. Needle out. Yes, inject. Saline तैयार रखना. Injected. Out. Will come out. Yeah. Okay. Yeah. काट दो ना इसको.
We'll be shifting to OT1 by Dr. Praveen Survanshi, sir.
Yes.
60 years old female, complaint of pain in abdomen, post-meal since 4 years. Generalized weakness since 2 months and black stools.
Section.
Colonoscopy by suggestion of multiple diverticulum with sigmoid colon polyp. Histopath report was suggestion of tubulovillous adenoma with low-grade dysplasia.
Hello.
Now patient is posted for endoscopic submucosal resection. Over to you, Suryavanshi, sir.
Hello.
Ha, Praveen.
Yes, Makaran. So as you know, mentioned in the history, this patient presented with mainly pain in very vague abdominal symptoms,
Yes.
for which she was evaluated, and you can appreciate there is a polyp in the sigmoid colon
Yes.
with multiple diverticula. Can you appreciate this diverticula?
Yes, yes, yes.
Wide mouth diverticula these are.
Yes, yes.
Okay.
Yes.
So she is having diverticulosis with sigmoid polyp. Now, if you classify these polyps based upon our Paris classification, so this is the semi-pedunculated.
Yes.
Okay.
Yes.
It is not very flat also, and it is not pedunculated also. Can you appreciate?
Yes, yes.
So it is semi-pedunculated polyp, and as far as NICE classification is concerned, so it is type 2, where it is a narrow band you can see.
Yes, yes.
See,
Better.
so it is darker than the surrounding mucosa. This is normal mucosa, and this is polyp. So it is darker than the surrounding mucosa, and also there is a fixed pattern. Can you appreciate this fixed pattern?
Yes, yes.
So this is the vascular and the epithelial pattern, which gives this appearance.
Likely
And
to be
which is-
adenomatous polyp.
So this is the adenomatous polyp.
Yes, yes.
Now it is not a very pedunculated polyp. It is very for the complete excision of the polyp. We must define this polyp before you start doing anything. Before you inject, just at the base of the polyp, or before you do marking also.
Yes.
So you must examine all the borders with narrow band, so that you make sure that everything comes out.
Yes. Yes.
There is no any residual lesion behind.
Yes, yes.
So once it is examined all around, then you can mark it before you inject submucosally.
Yes.
So that marking also important before injection. So with the TT knife, we will first mark this boundaries of this polyp on the narrow band imaging.
Yes, yes.
Okay. So you can, this is the polyp lesion and this is the normal mucosa. So you have to mark in between before you inject. TT knife. So these are a bit challenging lesions, these flat or semi-pedunculated lesions.
Yes.
especially when they are present at the some fold. Then the manure going submucosally becomes very challenging. But with experience, you can manage these.
What is the accessory you have applied to the tip?
Now this is TT knife, what we use for the poem.
Okay.
So at the end it is flat. So since I just want to mark, I don't want to make a cut. So I am using this flat surface of this TT knife.
So is there any accessory at the tip of the scope?
Pardon?
Any accessory at the tip of the scope?
This is a cap.
Okay.
You must use cap
Yes.
every time for any therapeutic endoscopy now.
Yes. Yes.
Or for ESD, EMR. So it helps to keep the mucosa away, and
Yes.
it gives operative distance.
Yes. Yes. Yes.
Open. Adge. Open. ठीक है. So it is not possible to go beyond the lesion and mark it.
Yes, yes.
Once we raise this, then we will able to get that the proximal margin of the lesion. Okay.
Yes.
Injection. So now we have two options, either EMR or ESD. In EMR, you just raise the lesion.
Yes.
And catch it in the snare,
yes.
and excise it.
Yes, yes.
So this can be done for the lesion which are not
Pedunculate.
suspicion of malignancy.
Yes.
They are like on type 2 lesions. But if you are suspecting any dysplastic changes at any point, anywhere, then better is the open. Do ESD. Inject. 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 Bas. Can you appreciate now?
Yes.
Whole
yes.
lesion is raised now. Okay.
Yes. Yes.
Snare. Snare. मोटी 30 चाहिए. 30 चाहिए. See now all these margins are raised.
Yes. Yes.
Fast. लवकर गया. So since there is no dysplasia and it is a benign lesion, we can take it out in piecemeal. Okay.
Yes. Yes.
Open. एक मिनट. Catch. एक मिनट. Catch. कैच के लिए एक मिनट. एक मिनट, open. Catch. Hello? Wash. You should take all possible time to confirm that the snare is
perfectly placed. Yes, yes.
And see, it should be mobile like this. That is the most important thing. If it is not freely moving, or if you have to use some force, then you are gone deep.
Yes, yes.
Can you appreciate how most of this is snare?
Yes, yes, mobility.
It has come. Just open. Open. Open thoda. Catch, catch, catch. Open. 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 Open, open, open. Catch, catch. Catch, huh? I think it's perfect now, huh?
Yes, yes.
Yeah?
Yes, yes.
Catch. Keep clips ready. Open. Catch. Open. Catch. Gently. Catch. ठीक है, हटा दे. Wash. Ah. Oh.
Is it necessary to apply clip?
See,
Yes, yes, wonderful,
Huh?
wonderful.
Completely,
wonderful.
huh?
Yes, yes, very nice.
See,
Yes, yes.
completely we are, huh?
Yes, yes. Is it necessary to clip?
We'll see. This oozing, there is no bleeding.
Yes.
See, there is no normal, huh?
Yes,
I don't
yes.
know what is tissue now.
Yes.
Can you appreciate?
Yes, yes, wonderful.
Even distally, huh?
Yes, yes.
मकरंद नक्की ना?
अगदी 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 100%. एकदा हे टाकून बघ ना NBI.
NBAच आहे ना आता.
अच्छा अच्छा अच्छा.
Sorry, sorry.
Yes, yes, yes.
एक मिनिट. See, this is
Yes.
normal mucosa.
Yes, yes.
This is the pedicle.
Yes.
And this is the distal.
Distal, normal.
Okay?
Yes, yes. Is it abnormal mucosa, Praveen?
Yeah.
That.
एक मिनिट.
I think you can apply another snare and remove it.
This much small is there.
Yes, yes, very small lesion.
That we will take out.
Yes.
Injection. Huh? And then?
Yeah. We are shifting to OT3 where they are deploying the stent for the hilar cholangiocarcinoma.
Yes, yes.
Mandar.
After a lot of efforts, I was able to pass the guide wire beyond the stricture. Can you show them the fluoro image? Can you get, sir, can you appreciate the air cholangiogram?
Yes, yes.
So now the stent is deep in the left system and I'll start deploying.
Yes.
Karu? Shoot chalu raha hai. The stricture was very tight and we had to change the guide wires.
Very difficult case. You have
Yeah.
done it successfully. Congratulations. Are you placing another stent in?
No. It is impossible.
Yes.
So can you see that proximal end of the stent which is inside the markers you can appreciate?
Yes, yes.
Oh. So now we have to be very careful, otherwise the stent will migrate inside.
Yes, yes.
So he is keeping the yellow marker continuously under vision on endoscopy. Karu? Now here we have come to a point of no return. Beyond this I will not be able to reload the stent.
Yes.
But that doesn't matter. Our proximal end is secure.
Yes, yes.
And we are not actually worried about the distal most part. Yes. Like this. Now the stent has completely been deployed and you will see gush of bile. Here also because of chronic obstruction the bile was white bile.
White, yes.
Great. Siam dakwa. So, can you see the fluoroscopy, sir?
Yes.
The proximal end is in the dilated part of the left duct.
Yes, yes. It was a wonderful demonstration.
Yeah,
yes.
and that narrow portion is where the stricture is.
Yes.
Now we can shift to the sir Soti.
Hello, Musali sir. Please shift the camera to
change it
Praveen's
to
photo.
straight tip wire. Yeah. Earlier we were trying with the J tip wire, so we changed to straight.
Yes, Praveen.
Shift to OT1.
That part.
Hello.
Okay.
Praveen. Yes.
So it was there.
Yes.
This is exercise. Now there is a small piece here also.
Yes.
That also I will exercise. ओपन करत ओपन catch.
Yes, it is wonderful.
One more is this.
Yes, yes.
Injection. So this we have to keep injecting because the whatever fluid you inject initially,
yes,
it get leaked out or it get absorbed.
Yes, yes.
So त्यानंतर लगेच छोटा घे स्मॉल स्नेअर घे हां इंजेक्ट निडल इंजेक्ट थांब इंजेक्ट थांब निडल हात पकड needle inject बस घे फास्ट घे open catch आला ठीक है
Yes, yes.
See now.
Perfect.
See, okay?
Yes, yes. What will be the follow-up of this case?
No, after 3 months.
Yes, yes.
एक मिनट
Have you retrieved the specimen?
See now. See now.
Yes, yes, yes.
Okay?
Yes, yes, yes.
Huh?
Yes, yes. Very nice.
Distillery also.
Yes. Have you retrieved all the specimens?
Not all major. This main specimen
Yes.
will take them. Sometimes it's become very difficult to catch them.
Ah, yeah. What is the size of the polyp?
Pardon?
What is
Polyp?
the size? Size of the polyp. Can you show it?
एक मिनट हाँ हाँ हो ना डिफिकल्ट चॅलेंजिंग होतं हां ग्रेट ग्रेट जेवण कर ना जेवण हां आलूच में झाली लास्ट केस भेटू आलूच में कुठे गेले बाबा? इकडे this polyp is in the cap.
Yes, yes.
Okay.
Yes, yes,
Man.
yes. Wonderful.
Thank you. ठीक है. Exam. ठीक है. Thank you.
Yes, yes, yes. Thank you, thank you.
Okay, now we'll shift to OT2, colonoscopy by Joy sir. 48-year-old female came with complaints of rectal bleeding since 8 months and pain while defecation since 8 months. On PR examination, patient has a fissure at 6 o'clock and a ulcerative lesion from 1 to 4 o'clock. Patient is now posted for colonoscopy with biopsy. Over to Joy sir.
Yeah, in fact, per rectal itself I can feel. Ma papa. There's a lot of bends in the sigmoid region. Now we have negotiated it and
yes, yes, yes.
We already have a finding, but I'm just screening the rest of the colon. We have a lesion at the tip,
yes,
which I will come towards the end. यहाँ पकड़ो. पकड़ लो उसको, पकड़ो उसको. You can see the appendicular orifice here.
Yes, yes.
Flush कर दो. Flush कर. This is the semilunar appearance.
Yes.
So we'll return and screen the rest of the colon and take the biopsy from the lesion as well.
Are you going for ileal intubation?
No, sir, I am not going because there is no need.
Yes.
There is no need. There is no undue. It would be an unnecessary intervention, I believe.
Yes.
पकड़ता है. So there are no polyps or any other lesion other than the primary lesion in the anorectal region.
Yes, yes.
Into the rectum.
Yes, yes, yes.
This is the lesion here.
Yes, yes.
Can you see it?
Yes, yes. this will be better seen with J manual.
Yeah, I'll try it, sir.
Yes, yes.
But again,
so it is not extending much.
yeah, not extending much. I'm going around and
Yes.
trying to see.
Yes, yes, yes. It is in the lowermost portion.
Yeah, this is the proximal most
Yes,
part
yes,
of the
proximal
lesion.
part. Yes, yes.
Let me see if I can take a biopsy from here.
Yes, yes.
Or else I'll do a simple proctoscopy and take it from below. I can
Yes,
feel
yes.
it very well. Biopsy forceps up. जाएगा नहीं ना biopsy bend होगा. On finger palpation it looks hard. It's a growth. Definitely it's a malignancy.
Yes, yes, yes.
But it is right behind the stem of this scope.
Yes. So if it is malignant, this patient will require AP resection.
No, sir. First, now the current guidelines, even if it is a small growth, it is better to go ahead for neoadjuvant chemoradiotherapy.
Yes,
Radiotherapy is the definitive.
Okay, okay.
So, I don't know if I will be able to.
Yes, it is bending further is a difficult task.
Yeah.
And reaching.
So what I'll do is I'll go.
Yes, yes, proctoscopy.
Proctoscopically and.
Yes,
take
that
it.
will be correct policy.
बाहर निकाल दो. प्रॉक्टोस्कोप लेके आ जाओ. बंद कर दो. निकल जाओ बाहर काट.
Yes, wonderful demonstration.
Thank you, sir. Thank you. We'll just do the proctoscopy and take the biopsy.
Yes, yes.
Okay. Thank you, sir.
Yes, thank you very much.
ले लो, निकाल दो ना मेरे कान से.
We'll see you in the lunch area.
Okay, sir.
Yes, sir. Thank you.
प्रॉक्टोस्कोप लेके आना ना. मंगवा लिया प्रॉक्टोस्कोप. बायोप्सी डालो ना. डाल दो बायोप्सी. डालो. हाँ हाँ एनोरेक्टल है. ये रहा. ये देखो. ये म्यूकोजा है इधर. देख रहे हो. नाउ हियर इज द स्क्वेमस और म्यूक. बायोप्सी डाल दो ना अंदर. जब तक प्रॉक्टोस्कोप नहीं आता तब तक बायोप्सी फॉर्सेप्स डाल दो. ले लेते हैं यहाँ से. ये सर एकदम टिप पे ही है. बस बायोप्सी ले रहे हैं. पकड़ना. स्कोप पकड़ा. हाँ ऐसा पकड़ा. यस. ओपन. टाइट पकड़ा है. कैच, कुछ आया? आया ना? इसको पकड़ो, इसको ओपन, कैच, चलो 1 मिनट रुक जा, नहीं नहीं, ओपन, कैच, आउट, ले लो, बायोप्सी है उसमें, प्रॉक्टोस्कोप दे देना, कुछ है पंच बायोप्सी कुछ? जेली लगा देना, चाहिए? हाँ, स्कोप चाहिए। एलिस नहीं, ओम फोर्सेप्स से ऐसा कुछ है तो कुछ भी आर्टरी से नहीं आएगा ना। सक्शन करना, सक्शन, इरिगेशन, कोई भी इंस्ट्रूमेंट दे दो जो है वो। एयर डालो, एयर डालते रहो ना। सक्शन, सक्शन, एलिस है, दूसरा कहीं नहीं, इसको पकड़। वेरी नाइस लीजन। सक करते रहना ना, सीस ब्लड। हाँ दिखाओ, विजन दिखाओ। लाइट दे देना। सक करो, सक करो। पकड़। वाला बायोप्सी लेके रखा है ना? नाक बंद, डालो अंदर। स्कोप लाइट दे दो मेरे को, बस ये पकड़ के रखो ना यहाँ टिप पे। ले लो बाइप्सी। सक करो। बाइप्सी पकड़ो, लाइट दो। हो गया। ऑस्पिस है। दूसरा एक एलिस दे दो। एलिस भी दूसरा एक है। मॉप करो। टेक दिस। 2 मिनट दबा के रख दो। झेलिया जुंदा। कौन इनको वार्ड में कौन देख रहे हैं? एक हाँ, एकदम गॉस पीस डाला हुआ है अंदर है। ठीक है, ठीक है, नोट कर दो उसके फाइंडिंग में ही। ठीक है, क्योंकि एकदम प्रॉक्सिमल एनोरेक्टल रीजन ही, इट इज अ रेक्टल ग्रोथ ओनली बट इट इज राइट एक्सटेंडिंग इनटू द एनल कैनाल। सो थोड़ा सा बड़ा बायोप्सी लिए। गॉस पीस भूलना मत है। Thank you.
सर चल गया
परवा वॉश देऊन प्युअर लिक्विड ॲटवर ठेवले होते. एंडोस्कोपी केली होती का?
Hello.
Hello.
We'll be starting with the last endoscopic procedure for the day. Procedure by Dr. Praveen Suryavanshi, sir. For 20 years old female, complaint of difficulty in swallowing since 3 years, aggravated since last 3 months. Oguroscopy, previous oguroscopy, suggested of dilated sigmoid esophagus with stagnant food particles, suggested of achalasia cardia, esophageal manometry, indicated relaxation pressure greater than 15, failed peristalsis, pan-esophageal pressurization, X-ray barium swallow suggested of dilatation of proximal esophagus with pooling of barium just proximal to G-junction, narrowing of contrast column at G-junction suggested of Achalasia cardia. This is the previous video of the gastroscopy. Patient is now planned for poem. Over to Suryavanshi, sir.
As we discussed yesterday, that before you start mucosotomy, this thorough wash is very important, because whatever is there in the esophagus will take it to the submucosal plane and there after into mediastinum. So this thorough wash has to be given. So that all these food particles, flakes, they don't go into the submucosal plane and You had lunch?
Yeah, that's why I rushed for the lunch because I thought before this starts, you had your lunch?
Yeah. Okay. Open. एक मिनट फॉर सब गया पकड़ होल्ड कैच ओपन open okay पकड़ catch open नहीं वो नहीं फ्लैप के जस्ट नीचे है एक मिनट ठीक है पकड़ रहे ये इधर है इसलिए पकड़ने को मुश्किल ओपन एक मिनट कुछ मत करो उसका इधर है गेट है ठीक है अभी क्या है एक्सटेंड हो गया अपना इंजेक्ट सलेंगे पकड़ Inject. Thumb. Inject. Open. Open. आगे. Open. Open. Inject. Open. Open. esophagitis mucosa भी थोड़ा सब is not esophagitis भी था बहुत था open catch
You are always towards the muscle layer. You never gone this side.
open and again stay perpendicular. So now we don't know how the esophagus is going. It's a close. Segment esophagus, na?
Yeah.
Open.
So the trick is to stay towards the muscularis and keep going,
No,
or
no. Trick is stay perpendicular to the circular muscle fiber. Yeah? So stay perpendicular to that.
then you turn
Wherever.
an angle so that the blade goes up. This moment is easy in cutting as a natural cut. And that I cut for first time.
Injured. Bas. Open. Injured. Bas. Bas. Open. Forceps. Open. Catch. Open. Catch. Inject. Bus. Open. Open. Catch. Open. Catch. Open. Catch. Open. Catch. Open. Catch. Very good. Catch. There. Injured. Bus. Very good. Oh, injured. Injured. Bus. Open. Engage. बस engage. बस open. और सब जब हम ना थोड़ा नहीं स्पेस कंस्ट्रेंट है because it's not getting lifted. Open. Catch. Open. Catch. The tunnel is not straight, it is like this.
There will be undulation with the esophagus also. This way also it will be. So at each and every kind the focus should be like circular muscle, perpendicular.
Inject. Yes. Yes. Open. ठीक है सगळे जेवण केलं ना सगळे ओपन क्लोज Today is very auspicious day in Maharashtra, Ekadashi. Open. So basically you are from Ahmedabad only?
I am basically a Kerala.
Okay.
Born and brought up in Mumbai. Then I studied in BJ Medical College, Ahmedabad.
Okay, okay.
Did my MS there. I was in Gangara. Did my MCH in medicine engineering. Worked with Dr. Subhash Gupta in liver transplant. Then joined Gangara, was almost settling there. Because at that time I had kids and Delhi ka pollution chalu ho gaya, so we had to leave Delhi. Then thought of settling in Ahmedabad. College friends there.
Open.
Now settled in Ahmedabad. So basically from all around the place.
Forceps. So your wife, if she is
She's a
gynec.
She is more of administrating in the hospital.
Oh, really? Which hospital? Yours? Okay. Not practicing.
Not really, because
Open.
practice नहीं है, बस OPD का ही है.
क्यों इतना प्रैक्टिस है तुम्हारा?
क्या सर?
तुम्हारा प्रैक्टिस इतना है?
नहीं सर, she is not interested. She is more of a literary person.
Open.
मेडिसिन में गलती से आके उसको बाद में realize हुआ.
Then it's okay. Open. She has gone for Elora? Oh, it was hectic yesterday.
Too hectic. She is more of a traveler. She likes traveling places, picking.
She is from where?
She is basically
Injured.
from Ahmedabad.
Okay.
4, 5, 6, 7, 8, 9.
Okay. Open. So Dr. Paramar, you must be knowing that. Okay. So now Dr. Apurva Shah is quite active, no? Academically there. Apurva Shah. He is very active, no?
He is active in the yes side.
No, otherwise also in Ahmedabad academics.
सर थोड़ा कम है, ये इस लेवल का नहीं है. ड्रॉबैक. वही नितिन सर को वही कह रहा था कि सर प्लीज कन्वर्ट एंडोस्कोपी वगैरह सिविल में तो लाइक इन आवर
Inject. सिनारा सब जगह वैसे जिधर है उधर कचरे में पड़ा है. ऑलमोस्ट ऑफ द हाँ एग्जैक्टली. Same story in most of the medical college. Those people are old timer, they could not catch it and they were feeling ashamed. Junior is doing and I am not able to do. So best way is to keep it in the locker. That was their strategy. Close, open. Inject. AJPJ, this one. Medical. Rajnish is there, na? Open.